Así que nada, buenos días a todos. Yo soy el doctor Ricardo Cumba, especialista de glaucoma en el Departamento de Oftalmología en Puerto Rico. Hoy empezamos el bloque de glaucoma por los próximos 3 días, hoy, mañana y el viernes. Tenemos el honor una vez más de tener al doctor Palmberg con nosotros. El doctor Palmberg lleva alrededor de 30 años. What is it? 30 years?
At least 30. I don't remember for sure what the first one was.
So, él lleva muchos años siendo parte y colaborador del curso básico Guillermo Pico de Oftalmología. Excelente especialista de glaucoma. Ha entrenado especialistas de glaucoma en Puerto Rico también. Y como pueden ver, parte del Instituto de Bascom Palmberg en Miami. Así que aprendan mucho, que todo lo que dice el doctor Palmberg es visto con buenos ojos en la comunidad de glaucoma, ¿ok? O sea que estamos escuchando a una de las personas de los pioneros en glaucoma. So now back to you, Dr. Palmer, go ahead.
Yes, thank you. Well, this is Bascom Palmer, and this is 25 years ago what our skyline looked like. It is now totally different. This is the Bascom Palmer main building, and then there's also across the street a 7-story research building. Just thought I would mention, you know, when I was your age, this is what I looked like. And American Medical News did a story on the new medical scientist training program that had just started. And I had been in the 6-year medical program at Northwestern, which accepted me to medical school out of high school. We had 2 very intense years of college, and then moved down to the medical campus. And after 2 years there, I had done some research during the summers and decided I wanted to be a medical scientist, that I wanted to be dual wired brain of biochemistry and ophthalmology. Actually, I knew that. My father was an ophthalmologist. I was headed to be an ophthalmologist from the time I was 14. And I went to see him in his practice, and I learned the most important thing probably I ever did, which was that he listened to the patients. He found out why they had come. And even if what they thought or were worried about wasn't really something that was a problem, he would explain things to them in terms they could understand. And if that's just being a good doctor. And so if somebody with dry eyes thinks their mother went blind from glaucoma, you need to explain that, yeah, they both have something to do with fluid in the eye, but they're totally unrelated, and you don't even have glaucoma, and don't worry, you're not going blind from glaucoma. So I was in this MD PhD program after 2 years of medical school, and my mentor was my role model, Albert Zeller, who was the head of the biochemistry department, and he had worked with Thaddeus Reichstein. He had done some research with him. Reichstein discovered corticosteroids. And also James Sumner, who was the first person to ever isolate an enzyme. And Dr. Zeller did research on monoamine oxidase. He named monoamine oxidase, and he realized that it was very important in processing, say, serotonin, which has to do with mood, and serotonin has to do with platelet aggregation, and that we're just starting to figure out biochemically, 55 years ago, how things work in the body. And I thought there are going to be things coming along in ophthalmology that I can work on. Well, I worked on an enzyme in the lens that's the garbage collector for denatured proteins. So when the exposure to light or just time denatures proteins in your lens, and you're starting towards getting nuclear sclerotic cataract, why, that enzyme eats it. And that works until you're about 70 years old, when the enzyme, being a protein itself, becomes denatured. And I I was working to try to perhaps be able to put messenger RNA to make this back into the lens, inject it into the lens. And no intraocular lens company was in the least bit interested in supporting this research. Of course, they would lose their business, but or they might if it worked. So have a plan for your career. I guess that's one of the messages I would have for you. Think, what would I like to accomplish in my life? And it may be taking care of patients very well. Get yourself prepared for that. Think about where you might want to do it. Do you want to subspecialize in some way? Is the area you're going to need somebody who's a glaucoma specialist or a retina specialist? How can you find a way of really fulfilling what you could do with your life? And these were my mentors in ophthalmology. Michael Cass was the chief resident when I came, and also then my mentor in glaucoma, and really taught me glaucoma surgery. And he was chairman for many years after Dr. Becker, who was chairman at the time, the guy who introduced using acetazolamide or Diamox as one of the last ditch treatments for glaucoma medically. And a very brilliant guy who read all the literature he could in science, like 70 different journals, in order also to look for these kind of connections, but didn't really have the training to always make the connections. But knowing that I was a biochemist, he would send me articles that he saw, and occasionally they were actually helpful in my research. And I was there for residency, clinical research, 2 years, and clinical fellowship and chief residency in 1971 to 77. And here are my parents, my father an ophthalmologist, and my mother a school psychologist. And here's my mother, my grandmother with my father. And she came to St. Louis, and I examined her eyes, and she was 20/20. My father had operated on his mother-in-law. I would never have done that, you know, but she'd had a perfect operation. She was, in this is intracap era, she was a +10 sphere, no astigmatism from his operation, even though there was a big wound in those days. And I could see that she'd had marvelous surgery. This is my wife, and here we were at about, you know, a few years older then than you are now, perhaps. At the time, we were heading off to St. Louis in 1980 with our 3 daughters, and a lot in front of us in life, and but wondering what it would be like. Doug Anderson invited me down to look at the department at Bascom Palmer, which at that time was a small department. It had invented vitrectomy, which changed the world, but it was a small department. There were 12 of us on the faculty, and now there are well over 100. And here I am young. This is Elizabeth Hodap, Douglas Anderson, Richard Parrish, and our fellow Marta Luz Araujo from Cali, Colombia, and Deborah Darnley. This is we used to have 2 fellows at a time. Now we have 4 in Miami and 2 in Palm Beach. Here are some of our fellows: David Greenfield, Don Budens, and some of my international fellows, including Jorge Lynch from Argentina, and this is she was from Australia, and she is from Brazil. So he was in the United States, but was from Vietnam originally. So these are some of our fellows over the years. This is my daughter who had cancer and died, and really wrote some very interesting things during that time. Like, if communion isn't a little edgy, you may not be doing it right. And here, as I've told you, 177 people told me that I looked like President Bush. Read my lips. I meant to say no nude Texans. Came out no new taxes. Wasn't going to tell them it was a mistake. Not going to do it. Wouldn't be prudent. And well, 177 people came up to me in that era when he was president, and this is actually Bush, not me. And he, a producer from Paramount Pictures came to Bascom Palmer and asked, where's that doctor who looks like Bush? We want to use him in a movie called Smoking Gun 33 1/3. It's a detective Dreblin comedy. And the person that they met in our development office said, we have no idea what you're talking about, sir. I came in 20 minutes later with a check with a donation from a patient to the development office, and they said, you won't believe what just happened. And they told me, and I said, give me his card. This would be fantastic. I've got daughters in college. Can you imagine being able to show, you know, yourself in a big Hollywood movie? And they said, well, we told him that there wasn't any such person, and he left, and he didn't leave a card. Anyway, this is me singing Elvis at the House of Blues in New Orleans. That's another story for another time, I guess. This is me as Micro Zorro. We'll talk about Micro Zorro later, things you can do at the slit lamp with a 30-gauge needle instead of having to take people to the operating room. And this is Teresa Chen from Harvard. And I had never realized that this kind of a costume could be a chick magnet. I was a very boring guy when I was in high school. I would have never had any idea how to do this sort of thing. Anyway, we'll get to the rest of that talk later. So I'm going to stop that one. And that's kind of an introduction. Oh, well, one other thing. This is the Life Achievement Award from the American Academy. This is the World Glaucoma Prize, and I'll tell you how that was won. And some places that I have visited. I ran the Boston Marathon in 1979, and I've been a visiting professor at you know, many places. Duke, Washington University, Wills, American Glaucoma Society. Now this one is interesting in that I went to India and took a barbelled implant, which is used in surgery when trabs fail or in certain special circumstances, a plastic drain to drain fluid out of the eye to back in the orbit over a plate. And I took one to them and they copied it. Now the barbell costs $600. The Ahmed usually costs about $450 in the US, maybe $200 in other countries. But it's just really not accessible in a lot of the third world for cost. And I took it to Aravind, and they made a very good copy. It's off patent, so that's allowed. And they make it for $30. I think they sell it for $50 if it goes out of their country. And I understand some countries in the Latin America, there are companies selling it for $200. That's too much of a markup. But at any rate, I went to India and I spent 3 weeks teaching them how to put them in. And they're now in 17,000 eyes in 63 countries. So my goal of trying to bring glaucoma care to the third world, or the developing world, this is part of it. Another part was training 108 doctors from other countries who came and studied with me at Bascom Palmer and went back and are now, many of them are now teaching, even presidents of glaucoma societies in Ecuador and Venezuela and Argentina, and they've gone to Brazil, Dominican Republic, Colombia. There are 10 in Colombia and 10 in Brazil, 9 in Dominican Republic. And my goal was to train people to teach glaucoma in other countries. And so that's really one of the major roles of my life, has been to train people to understand and to treat glaucoma, and then to come up with better ways of doing things that are safer. And we'll get into those. Then this is, I got the Surgery Day lectureship from the American Glaucoma Society, and they had a roast for me with our fellows at the Cosmos Club. And And here are people like Dale Hoyer, and Lee Allward is in there, and Kuldev Singh, and a lot of, here's Kuldev, a lot of glaucoma specialists in the United States were there then. And then this is my family in 2012 at Christmas, and unfortunately, this is our daughter who then died of leukemia. And so there are ups and downs in life, and you got to be prepared for them. This was a flash mob of fellows in 2018 in New York when I got the Educator of the Year award from the American Glaucoma Society. So looking back on my career, I'd say probably the most important thing I've done is being lucky enough to be associated with people that I could train, bright young people who've gone back to teach others and to take care of patients. And, you know, a career in academics of teaching people can be extremely rewarding. So I give you this background about me to say that it's something to consider. If that you have some desire to teach, do it. Stay with it. All right, well, let's go on to gonioscopy. I think we probably have everybody here who's going to come now. And so again, here's Bascom Palmer, and we do not actually have the sign on the building, 7 things to remember about gonioscopy. And I will put this on slideshow, and here we go. Now, I don't have a financial interest in this, and I regret not having a financial interest in this particular thing. But anyway, the first thing to know about gonioscopy or examining patients at the slit lamp is get comfortable. You and the patient should be vertically sitting straight up. Don't be leaning forward. You do that, your back is going to be killing you at the end of the day. And have the patient sitting up. If this patient I'm trying to do gonioscopy on were leaning way forward, they would have to look up to have their eyes straight ahead at you. And your gonioprism might just run into their brow, underside of their brow, and it might be very difficult to do. And they won't be comfortable, and they won't be able to be still. So you want them vertical, which means sliding the slit lamp up to them. This can be a problem for people who are heavy chested, you know, are got a lot of fat, getting it to unfortunately, the slit lamp tables were not thought about very carefully about how you could slide a slit lamp into somebody without running into their chest. But get it in as close as you can. Adjust their chair height so that there's a little mark usually on the slit lamp which should be the height of the patient in order for you to adjust up and down, having them in the proper position for you to look at them. And you slide in, you can spread your knees apart. I would say to ladies, you may want to wear culottes, you know, the kind of pants that have a leg on each side, or pants, so that you can slide in close. It'd be very hard to do this with your knees spread a little apart at the slit lamp otherwise. And get in close so that you're vertical. Support your elbow, either with the table if your arm's long enough, or put a little piece of wood, a little round dowling 2 or 3, 4 inches tall, under your elbow, so you can rest all the weight of your arm on it. And then put your fingers against the patient's cheek or this bar to support you, so that when you apply the gonioprism, you can apply it very precisely with just moving your fingertips. Now, in surgery, to not shake when you're doing eye surgery, you don't want to shake when you're doing eye surgery. You can't do eye surgery really very well if your hand is up in the air while you're doing things. You want to also sit vertically in the chair when you're operating. Let the weight of your arm hang at your side, and put the palm on the patient's forehead or cheek when you're working, and then just work with your fingertips. Now, I figured this out by watching a jeweler who was fixing my watch. They were changing the battery in the watch. And I wondered, how can they do something so delicate? And I watched him to see what he was doing, and that's what he did. He was just working with his fingertips, having supported all the weight everywhere else. Otherwise, if your hands are up in the air while you're trying to examine somebody's eye with a 90-diopter lens to look through their pupil, you're going to be shaking side to side. You're doing gonioscopy, you'll inadvertently be pushing on the eye, which will maybe deepen an angle closure patient and make the angle look open. And you'll be sliding side to side. And you can avoid all that. You can be very precise. About 3 or 4 years ago, I was up in Maine giving a talk at a meeting, and a doctor came to me who's a retina specialist there, and he said, I want to tell you that in my 2nd year of residency, you changed my life. And I thought, what? You know? And he said, yes. He said, I didn't think I was steady enough to be a retinal surgeon. But when I came on the glaucoma service, you told me that you were going to try to teach me things that, even though I knew I wanted to go into retina, you were going to try to teach me things on the glaucoma service that would apply to what I was going to do in retina, and particularly the interactions of glaucoma and retina, but surgically, how to hold instruments and how to support the weight of my hand. And he said, and after I did what you said, the arm just dangling down, right up your belly, right up against the table as much as you can, so you're sitting vertically, palm on the side of your palm on the patient's forehead, or if you're sitting at the side, it's also, it can be on the forehead for a right-handed person in the left eye, for example, and working with your fingertips. He said, then I realized I was not shaking anymore. I could do very precise things, and I was able to be a retina surgeon. And I thought, gosh, how did he get that far along in the residency and nobody taught him that? So at any rate, all the residents who come through Bascom Palmer over these years, it's now about 300 residents that have all been told this story. So that is one of the most important things about gonioscopy is be comfortable, have the patient comfortable. And next, I like to use this kind of a gonio prism, but it's really not available anymore. But you can see that with the mirrors of the 4-mirror Zeiss, and you can get this kind of Zeiss mirror on a stick, it's called a Posner, or you can just simply get one that you hold by a rim and put it into the patient's eye, so that you can see in the mirrors, you can see what's going on in the angle of the eye. That is where the trabecular meshwork is, where fluid is getting out of the eye, and I'll get into the details of that later. Well, the next thing to do is, if you're examining a patient, you need to do this gonioscopy in a dark room. And the reason for that is light constricts the pupil and can open a closed angle, that is one in which the iris is semi-dilated in the dark. The pupil gets larger, and it can get to a position where the fluid passage between the lens and the iris has some resistance, and the maximum is at a mid-dilated pupil. And this can cause the pressure to build up behind the iris and lift up the peripheral iris to cover the drain of the eye, the trabecular meshwork, and we call this angle closure. And if it results in an elevated, if it's actually, the fluid is, the aqueous that flows in the eye can't get to the drain, why the pressure starts to build up in the eye. But if you have a light through the pupil, you will not be able to see that, you will not detect that this patient actually, in dark situations, has a closed, part of the drain closed. And it's a circumferential drain, so if only half of it's closed at a time, the pressure may not build up enough to cause the patient to have pain from a high pressure and cause an angle closure attack if it closes 360. But nevertheless, they can be getting high enough pressure to damage their nerve and to begin to form adhesions between the iris and the drain. So not having light go through the pupil, this was demonstrated by Gus Gazard from the University of London, where they did UBMs, ultrasound biomicroscopy, in the dark, and was able to show the difference between light and dark, opening and closing angles. And these papers are important papers that talk about how this takes place, and show actual pictures of it. And I was asked to write an editorial about it for the archives, and I did, and I called it Shedding Light on Gonioscopy. The term shed is one of 7 words in English that means something and is also its opposite. And in this case, you don't want to put light, shed light. You want to not use it, which is also called shedding. So light constricts pupils, it can open dark, it can open angles. And also don't use a fixation light for the patient's other eye, because accommodation also causes the pupil to constrict. And these days, if your computers are really bright in the room, that might be very bright. Maybe that screen should not be aimed towards the person you're examining. But do it in a dark room. Find a way to turn off the lights in the room to do gonioscopies when you're looking for angle closure. And think about it, people who get angle closure glaucoma attacks, when does it happen? It happens, they come out of a movie theater at night into a dark place, and it happens. These attacks usually happen under dark lighting situations. But when you go to sleep, curiously enough, your pupil constricts, and it gets out of that mid position, which is really the problem. So sometimes people have an attack and they go to sleep, and the attack goes away. Well, let's go on to this. When you're examining the grain, you put in a narrow, short beam of light. So your slit lamp needs to be adjusted to have a well-focused slit of light. And sometimes after the slit lamp's been around for a while, it gets out of focus. And if you have technical staff, they can come and adjust little screws in the slit lamp to make it a sharp beam of light. And you're going to shine that beam of light into the eye, across the iris surface, and towards the back of the cornea and the angle, the place where fluid's going out. And you'll notice something, in this picture that's supplied by the University of Iowa, the cornea does not end abruptly as a vertical line. The cornea goes further back inside the eye than at the surface. And you may not have realized that, but when you look at somebody's eye in surgery and you see a blue zone just behind the cornea, and you wonder, well, why is that blue? Well, that's scattered light from the anterior chamber coming up through the cornea. And scattered light, remember, scattered light is blue. That's why the sky is blue. The sun is not blue, but it contains blue light, and the scattered blue light from particles in the atmosphere gives us a blue light. And if you look more directly at the sun near sunset, it looks red, because those are the more directly aimed lights that's not being scattered away. But at any rate, this beam of light shown into the angle allows you to see a 3-dimensional figure of light in the cornea. But as soon as you get down to this area, which is the junction between the cornea and the drainage part of the eye called the trabecular meshwork, you get to a point of this intersection. It's called Schwabe's line. And there's actually a little group of cells there, and it looks a little brighter, a little bit whiter than the sclera in other places. And then when you're over the trabecular meshwork, where there are openings between the beams of the trabecular meshwork, and we'll show that structure later, why some of that light is absorbed, so it doesn't come back to the surface. And so this area looks algún gris, it's a little gray. And when you see this transition from a bright light in the cornea, and particularly right at Schwabe's line, to something gray, Now you're looking at the trabecular meshwork. Now, pigment particles coming off the iris, particularly the back of the iris, which has the pigment epithelium, those particles go with the flow, and they can settle into the functional portion of the trabecular meshwork, and you can see a pigmented line. Now, in this illustration, this is someone who has almost no pigment in the trabecular meshwork, but you can still tell where the trabecular meshwork is because of this transition from a bright light, three-dimensional bright light, to a two-dimensional light on the trabecular meshwork that is a little gray, a little grease. And then you get to the scleral spur. In most people's eyes, there's a little bit of sclera behind the functional trabecular meshwork. Some of the sclera, and the sclera is solid white, and so if the iris insertion in the wall of the eye is behind that, you will see a bright white light again. And then behind that, if the insertion of the iris is even further back, you may be able to see some of the ciliary body, which will be gray or brown. And I'll show you examples. Now, during development, at about 6 months in your mother's womb, your iris was up here. And during development, the iris, as things developed differently in the two eyes, and during the structures inside the eye developed in different ways, the iris attachment, its association with the wall of the eye gets further and further back. And in myopes who get larger eyes, why it can insert farther enough back that you can see the ciliary body, and myopes having longer eyes. And in some hyperopes, people who end up with eyes a little shorter than the average of 23 millimeters, why they can end up with the iris inserting right about the scleral spur, and you don't see the ciliary body. And in congenital glaucoma, this process is somewhat arrested because it requires the death of cells in this area, some apoptosis, to develop the pores in the trabecular meshwork and for the iris to move back. And in children with primary congenital glaucoma, which will be discussed by one of the other professors in this course, what one does is to use a knife to cut where the iris is attached to the wall of the eye up here and let the iris fall back. There's been enough development behind, but there hasn't been an apoptosis, a programmed cell death of some of the cells that need to go away to allow the iris to fall back to its proper position. It's like cutting the strap on an accordion and having it pop open. So this surgery called goniotomy severs the attachments that should have gone away but didn't during development, and allows the drain to come open and aqueous to get to the trabecular meshwork. Now, aqueous production starts at about 6 months in the womb, and that's just about the time that the trabecular meshwork first becomes exposed to the aqueous. So it's an amazing process as the eye develops, that the timing of these events is just right in order for things to develop well. So let's go on to the next slide. Let's see, where is... Now here is that transition zone. I'm showing you a very magnified view through a gonioprism, and you see this bright three-dimensional figure of light in the cornea. It's three-dimensional, meaning it's broader. And then you get down to Schwabe's line, the edge of the cornea, and now you see that this area, which doesn't happen to have much pigment, is gray. It's less bright. And so you'd say, okay, there's the cornea, there's the trabecular meshwork. And you're able to tell the difference. And so this ribbon of light that you put in there, this slit beam, on the iris, on the trabecular meshwork, is not penetrating those tissues, so it stays that width. But since you're shining this from a 30 or 45 degree angle to the side where it gets in the cornea, it looks wider and also it looks brighter. Here's another example of somebody who got a longer eye. We see the bright light in the cornea. the transition to the trabecular meshwork region right here at Schwabe's line. And in this case, you can see the scleral spur, the sclera brighter and clear again. There is a little pigment in the trabecular meshwork. And here you can see the ciliary body. This is someone where the insertion of the iris has moved that far back during development. And now you can even see the beginning of the ciliary body, the tissue that pumps fluid into the eye and also has a muscles inside it that control accommodation. Well, now here's a very magnified picture of an angle in a patient who has a condition called pigmentary dispersion or pigmentary glaucoma. And in some myopic eyes, the iris drapes backwards. Well, the flow is coming from behind the iris forward. But every time you blink, the pressure in the eye for a few microseconds goes up to 30 in a normal person's eye. But just for a very fleeting when you blink, pushing fluid through the pupil into the anterior chamber from behind the iris. And if you have kind of a floppy iris for some reason in myopes, that fluid in the front, instead of going back when the blink is no longer creating pressure in the eye, it can stay there and push the iris back away from the direction of the flow. So the flow is intermittent. Now, if somebody like this, and Bob Rich has done this in New York, they had a patient who had pigmentary dispersion, was able to just not blink for 9 minutes. This posterior bend, posterior curvature of the iris went away. So it showed that it's not an anatomical normal situation. It's due to the reverse pressure gradient across the iris, pushing the iris back against the zonular fibers that hold the lens in place. And this can cause the back surface of the iris to rub off pigment. And those particles can come through the pupil and settle in the trabecular meshwork. So this is a very magnified view of the trabecular meshwork. There's cornea, here's trabecular meshwork, and down here is scleral spur and then ciliary body. But look at this pigment, really heavy pigment. When you see pigment that heavy, it's not natural. And that's either pigment coming rubbed off the iris by the mechanism I've just talked to you about, pigment dispersion syndrome or pigmentary glaucoma, or people who have an abnormal material called pseudoexfoliation deposited on the lens, very abnormal material. We're still not quite sure why it forms, but when it does, and the iris contracts and the pupil expands and contracts, the iris around the pupil for the interior third of the cornea, closest to the pupil, some of the pigment can be rubbed off, and that pigment can come through and settle in the trabecular meshwork as well. So either of these conditions can have pigment increase on the trabecular meshwork. There's also a very rare cause, which would be a melanoma in the eye, shedding cells that could cause pigment, but that's very rare. But notice there's another line here right at the edge of the cornea. And that's called a Sampolesi line after Roberto Sampolesi, famous Argentinian ophthalmologist who described this. And these are larger particles of pigment that have rubbed off the iris in cases of pseudoexfoliation generally. Can be in pigmentary, but usually pseudoexfoliation. And notice the character of the pigment is different. In the true trabecular meshwork, the pigment particles are quite fine, and they look like fine powdered brown sugar, and they're in a continuous line, as opposed to the Sampolesi line. Now, what is the Sampolesi line? How does that form? Well, there's a change in curvature from the curvature of the cornea to the curvature of the angle. And at that bend, that change in curvature, it's like a shelf. And on that shelf, the pigment particles can settle. And if they settle on that shelf, they can make a line. But notice that these are larger particles and there are gap spaces in between where you're just seeing the underlying tissue. So I say this looks like salt and pepper. The salt is actually just areas that don't have any pigment, and then the pepper are these lighter gray and larger particles that look like pepper to me. And so you have salt and pepper. If you see a salt and pepper looking discontinuous line, and that's all you see, be careful. There are ways of seeing deeper into the angle, and look for a line that is a continuous line of fine powdered brown sugar. If you don't see this continuous for a long period of time, maybe that angle is actually closed, and I will show you examples. Now let's talk about the lenses that people use to look in the eye. There are two basic types. There's the Goldmann type of lens, which has an interior rim of 11 millimeters, and then this exterior rim of 13 millimeters. Well, how wide is the cornea? The cornea is about 11 to 11.5 millimeters wide in adults. And that means that this device, when it's put on the eye, is not put on the cornea, it's put over the sclera. And the vault curvature of this lens that you're going to put on the eye is steeper than the curvature of the cornea. So you have to fill the space in here with something like a methylcellulose gel. And some of those gels, they've got some better ones now that don't run out so quickly, but the methylcellulose that we used to use, that we would put in here, you had to get this on the patient's eye quickly or it would just run out on the floor or on the patient's cheek as you were trying to put the lens onto the person's eye. And because of this steeper curvature, you have to push it on the lens a little bit to get it into position. And when you do that, you force a little of the fluid out and it creates a suction cup effect. You know those things you use to plunge toilets that you push it in and pull out and push in and pull out to get your toilet unstuck? When somebody from North America doesn't realize you don't throw the toilet paper in the toilet because it can clog it. And they may wonder, why do people put the toilet paper in the inodoro in America, and they don't do that in a lot of Latin America? You ever know why? Well, because the toilet, I had a patient from Brazil who worked at his job was going around selling pulp for toilet paper to people in different countries. And he said, in the United States, if you put the toilet paper in water, it dissolves rather quickly into tiny little, tiny particles that can go down the toilet. And in Latin America, in many places, the toilet paper does not come apart when it's wet, and it would clog the toilet. And that's why you have that little basket that you throw the toilet paper in. So if you wonder, why is there no basket next to the toilet when you come to North America? That's the reason. And the Germans like their toilet paper really rough and uncomfortably rough. And so if you go to Germany, bring your own toilet paper roll with you. If, don't want to feel like you're wiping with a corn cob. Well, that's probably too much detail. But anyway, you push this on and it creates a suction cup effect on the eye that holds the lens on the eye. Well, that's wonderful if you're a beginning person, because once you pushed it on there and it sucks on the eye, it doesn't have a tendency to come loose. And so it makes it easy for you then to examine the patient. The problem is that the Goldmann lens sucks. It sucks on the cornea, but that's a problem. Anything that pushes on the eye or sucking on it has the same effect. It raises the pressure in the eye. And as I will show you, if you raise the pressure in the eye by accidentally pushing on the eye or by the suction cup effect, you can open an angle that's actually closed, that the patient really has angle closure, and you're going to miss it if you use the Goldmann lens. So if you ask glaucoma specialists in North America, 95% of them use the Zeiss type of lens to examine. It doesn't create a suction cup. But if I've gone around the world and I've given a lecture on gonioscopy in, I don't know, 60 countries or something, and in most of the states in the United States. If you ask the audience, 2/3 of ophthalmologists at least or more use the Goldmann type of lens because it's so much easier to get on and have it stay on. Now, the Zeiss lens, as I say, 95% of glaucoma specialists use, or ophthalmologists who have been trained in San Francisco, St. Louis, Miami, or Boston know better, and New York, because they have had people who are explaining it to them that if you use this lens, you're going to miss angle closure some of the time. So a Zeiss type of lens is essential to examine those patients. Now let's think about it. It has a 9 diopter interior rim, so it's fitting entirely on the cornea if the patient's looking straight ahead. And the vault of this lens is very close to the curvature of the cornea. So you don't need any goo in here. You can just put a drop of the anesthetic, topical anesthetic. Of course, you always do this after putting in anesthetic. And proparacaine takes about 20 seconds to numb the eye. Tetracaine takes about 1 minute. So after you put that drop in, you do want to wait that amount of time. And then you put this lens on, and you need to put the Zeiss lens on without accidentally pushing in order to examine the drain. So let's put it on the eye and let's see, what do we see? Here's a patient that with Zeiss gonioscopy and no light going through the pupil, the angle was closed. I see the cornea. I do not see any trabecular meshwork. This is bright all the way down to the horizon. The iris is against the drain. They had been sent to me for a laser trabeculoplasty from a country in Central America. And I said, well, you do need a laser, but it turned out that the reason their pressure was elevated was that they had angle closure, but it was reversible closure when the light was on. Now, the picture I took with a narrow beam showed, but with a Goldmann lens creating suction, also was open. But I've opened this up. I'm showing you the one where there's more light. Of course, that'll open the angle even more than just the section. But the only way you'd know this was angle closure is to see these adhesions between the iris, this broad area of iris stuck to the drain there and here and here, and in between open so that you can see the pigment. So if the iris in the dark is forward, is ballooned forward by a pressure gradient, and it's in contact for enough time, eventually there will form adhesions between the cells of the surface of the iris and the trabecular meshwork, and then it gets stuck. And even if you were to pull that open sometime in the future, that area might or might not function, if it's because the trabecular meshwork cells depend on the aqueous to feed them. And if those cells die, then the meshwork may be scarred in a way that's not going to function even if you pull the iris away from it. It might or might not, depending on how long it's been closed. Well, now the next thing is you have to adjust your point of view. If you're trying to look down a narrow crack between the iris that has a little ballooning forward and the back of the cornea, you need to have the patient look in the direction of your mirror about 15 degrees or so, or you have to tilt the lens, but it's easier to say just look down a little bit. And when they do, I can now see the trabecular meshwork in this eye. I call it a dive bomber view, coming down out of the sky to see down into the drain. On the other hand, if you want to do laser treatment with selective laser trabeculoplasty or argon laser trabeculoplasty to treat the drain, which are effective treatments for pressure, and very recently the selective laser has been shown in the LIGHT, L-I-G-H-T study in England to be more effective at lowering pressure and preventing glaucoma damage in people who have early glaucoma or getting more damage from pressure, to do a laser a selective laser trabeculoplasty, applying laser to the drain, than starting out with drops. And of course, then the patient doesn't have to be compliant in taking medicine during that time, but they do need to be compliant in coming back for visits, because that treatment is not necessarily going to be permanent. It may only last 3, 5, 7 years, 9 years, sometimes more, but it's very effective. Anyway, but to do that, what do you want to do? You tell the patient to look away from the mirror you're looking in, and then you're able to apply the laser. Now look, if you were applying laser here in the slide, on the left part of the slide, it'd be very hard to get that laser in there right. You want to be as parallel to the iris and perpendicular to the trabecular meshwork as you can be to a curved surface. And so what do you want to do? You want to be looking in the very center of the mirror, top to bottom and left to right. That is the sharpest view you have to apply laser treatment. But this obviously is an eye where the angle is actually quite well open, and therefore we can see. Now, if this had been an eye with a lot of curvature of the iris, we wouldn't be seeing the trabecular meshwork. We would have to have the patient look in the direction of mirror to see over the curvature of the iris to see whether it was actually just a bit open or it was closed. I call this a cruise missile view. You know, the cruise missiles come along the surface. And so the cruise missile view for trabeculoplasty is the way to do it, to be perpendicular to the trabecular meshwork. And as you're applying the laser, you should rotate it, hold the mirror, or the gonioprism, with 3 fingers, so that you can be moving it around as you're making the shots. Don't hold it with 2, because you can't rotate very much. The ideal thing would be to rotate with each shot. And so you're always in the center, but you're moving along, and you can see various areas of pigment in the angle or spots on the iris to keep track of where you are as you're rotating to the next spot. And maybe just doing 1 or 2 or 3 shots and then rotate a little more, and always staying in the center of the mirror when you're doing laser treatment, the gonioscopy for laser treatment. Well, here's what I was talking about before. This is from Rich Shields and Kruppen, a wonderful textbook. Unfortunately, I don't think it's been revised in a very long time. And but if you can see, with some curvature of the iris, but not a closed angle, if the patient looks directly ahead, you will miss angle closure. I mean, you'll think they have angle, you might think they had angle closure, and they don't. And this is my argument against the World Health Organization's standard of using a Goldmann lens and having the patient look straight ahead. And if you don't see the trabecular meshwork, they say the angle's closed. Well, that's not true. It's crazy. What you want to do is use a Zeiss type of lens and have the patient look down about 15 degrees. Now the light beam coming in from your slit beam bounces off the mirror, goes across the cornea where it is diverted some, and goes into the angle, and you can see it's open. And you don't need a laser iridotomy in this eye. Now, the treatment of an eye that does have appositional closure is under a lot of debate right now. My preferred thing, and I wrote an editorial on this recently, is if you have appositional closure of a clock hour or 2, I would make a hole in the iris, because that's somebody who is going to form adhesions and lose some function of the angle. If, however, you have adhesions have already formed in perhaps half the angle, or the pressure is 30 or higher, there is, and there are some adhesions, then taking the lens out of the eye can be helpful in deepening the anterior chamber. Obviously, you're not going to have pupil block once the lens is out and replaced with a thin intraocular lens. But it does not apply to acute attacks of angle closure, where I think everybody still agrees the laser iridotomy is the answer, not trying to go and take the lens out of the eye. And if all of the drain is closed by adhesions, neither iridotomy nor taking out the lens is going to answer the problem. You need a new drain for the eye. You need a trabeculectomy or some other way of draining fluid out of the eye. but we'll get to that. But while you're using the Zeiss lens, you have to be careful you're not pushing in, because you can actually distort the cornea, push it in and close the drain artifactually. So you need to support the weight, put your fingers on the side of the patient's face, and then gently put the lens against the eye to see what the natural condition of the eye is. But if you then do not see the drain, you have to get pushy. And that's number 7, indentation gonioscopy. Now, I don't know if any of you have any idea who invented indentation gonioscopy. A second-year resident named Calvin Hughes at Washington University in St. Louis invented indentation gonioscopy. And he then taught it to Robert Moses, who was a faculty member, who taught it to Dr. Becker, who taught it to Max Forbes, who published the article and gets the credit, although he says, hey, I was taught this by Dr. Becker and Dr. Moses. And later on, Max Forbes chased down the story and found out it was a second-year resident. A second-year resident. I'm going to tell you another story later on about a second-year resident who saved the intraocular lens industry. I happen to be slightly involved in that story, so I'll tell you that one later. But second-year residents can see things sometimes that their professors have not seen and can come up with something better. So keep thinking. You're not just being taught, you're being taught, hopefully you're being taught to think, not just how to do something the way other people did it. If you understand the principles of what's going on, you may have an insight that puts us ahead. Well, look at the character of the pigment here. It's discontinuous, isn't it? It's like salt and pepper. And there is also a slight bowing of the iris. And so what do you need to do? Well, with the Zeiss lens, you can do what's called indentation gonioscopy. With the Goldmann lens, it's very difficult to do good indentation gonioscopy because it only pushes on the sclera. But if you, with the Zeiss lens, you're looking having the patient look down about 15 degrees, and let's say we're looking at the superior angle, which when angle closure takes place, it's usually first takes place superiorly or nasally. Those are the two parts of the angle that, as things go in development, end up being narrower than the temporal and inferior portions of the angle. So that's where you first want to look, is at the superior angle. You're looking in the inferior mirror so that you can look up into the superior drain. And when you see this, what you do is you push in and you lift. You push in and you lift. And when you do that, you now see that what you were looking at before was a Sampolesi line, and here is the true trabecular meshwork with adhesions there and there and there and there, and smudged pigment on the drain. Now, when you're looking in and there are adhesions, and these are called peripheral anterior synechia, PAS. And in Spanish, somebody tell me, what is the acronym for peripheral anterior synechia? It's something a little different. But I call them adhesions because everybody understands that word. Wherever the iris is tethered to the trabecular meshwork, it's actually been against it long enough that it started to form an adhesion, but it may be intermittent, and areas in between may not be stuck yet. And as you see, when I push in on the eye, this part of the iris cannot move posteriorly. But right next to it, this portion can move posteriorly, and so it bends back down and shows you the true trabecular meshwork. And here was the Sampolesi line above it. Now notice this picture is pretty clear. If you just simply push in on your gonioprism, you will buckle the cornea, and optically it'll be irregular and it'll be very hard to see what's going on. So what you want to do is a regular indentation. That is, if you push and lift, the inferior third of the rim of a Zeiss lens will push the cornea in, but it will not optically distort your view. So instead of just pushing in, push and lift to look at the superior angle. And if you're looking at the side mirrors, you have to have the patient look 15 degrees one way or the other and push against the direction they have looked. And you will also selectively deepen the chamber opposite where you're pushing. So you'll get a really clear view and really have the most deepening that is possible by pushing in the cornea in a selective area, inferior third, when you're looking superior. And it moves back and forth. If you push and let go, you'll see this iris move down and back, and this area tethered. And that tells you for sure this was definitely an adhesion, a peripheral anterior synechia, and not an iris process. Now, during development, we all had tissue over the trabecular meshwork. I told you how that goes away during development. Well, it doesn't always go away. And if you should see, I'm not showing you a picture of it, but if you should see something that looks like fine Spanish lace draped over part of the angle and has like holes in it, that is just something that didn't go away during development, and it's perfectly natural and normal, and it does not affect the flow of aqueous. So you don't need to do anything about that. And it doesn't tether the iris when you push back. It will open up. And those are called iris processes. Well, here's another case. We see a line. It looks like salt and pepper. Let's push. Voila, there was the Sampalesi line again. Now here's the true trabecular meshwork all the way down to scleral spur. So this is somebody that if we make a hole in the iris to relieve the pressure gradient across the iris, the angle will open and function, and the patient won't develop adhesions, and they won't get glaucoma, and you're a hero. Well, let's say you make a laser iridotomy, and you still need to go back and look at the angle and see what the situation is afterwards. Here's a very adequate laser iridotomy. Now, where do you put the iridotomy? I prefer to put them temporally, or you can put them superiorly. The problem with that is if this patient's natural eyelid position is such that the tear film meniscus is over that hole, they just happen to have really nice wide open eyes, the light coming through here will go back to the retina. And when they're walking down a dark hall towards a window, they will see a blue light, a horizontal blue light in their vision. That if they let their eyelid down a little bit, it'll go away. Or if they open up wider, it'll go away. And the reason is the tear film meniscus is acting as a prism on the light and focusing the blue light on the retina. And it's pretty annoying. So you want to look at their natural eyelid position to decide where to put it. I prefer to put it temporally and to have the patient look temporally while I'm making the hole in the iris, so that the hole is actually just over ciliary processes out there, and that the light is going out to the side because the patient is looking out temporally while I'm doing the treatment, and therefore the light is not going towards the retina. Now, the light is so unfocused, the iridotomy light is so unfocused by the time it gets to the retina. You're not going to burn the retina unless you really have moved the slit lamp very far forward and the pupil is dilated. So that doesn't happen, but I would prefer to put it here with the patient looking temporally and treated temporally. Well, here's a laser iridotomy. First, you want to find a crypt. If you're using a YAG laser, something like 3 to 5 millijoules is good. Find a crypt and focus to the smallest laser spot. Now, that may differ from the optical focus. So after you find the spot, move it in and out to get that spot as small as possible. Also, if you're chasing the light to the patient's moving eye, it's kind of difficult. And it's easier if you have this. This is where it's helpful to have the Goldmann lens with its suction on the eye. It creates a suction cup. And you can use it to pull the eye a little in or out, or left, right, up, and down, to bring it to the laser spot before you shoot. instead of trying to hold the lens steady and move the slit lamp to focus the spot, once you get it close, the final adjustment is done by pulling the eye, pulling the eye to the spot. And so focus to the small, find a crypt, that's where it looks like the iris is thinnest. Focus to the smallest possible laser spot, which may not be the same as the optical focus on the slit lamp of that laser, YAG laser, or if you use argon, the same principle applies. Pull the eye to the spot, and then watch for a gush of fluid. Now watch this as this is being done. You will see some pigment come through when you've gotten a perforation. But you're still not necessarily done. There, you see some pigment coming through? You're still not necessarily done. And why is that? Well, because the back of the iris has the pigment epithelium attached to the stroma. And it's like clods of mud stuck to grass. And after you've made this hole, the flow of aqueous can cause some of this adjacent pigment epithelium attached to iris stroma to swing into the hole. And you may not have a large enough hole. You need a hole probably 50 to 100 microns, which is about twice the size of this light, to really be sure that you have a hole that's going to be sufficient. And you see that some pigment gets out in front of where you've made this when it gushes forward. And I invented something and published it years ago called the shuffle technique. And what is that? You push in and out on the lens. And it's like squishing your teeth when after you've brushed them to get the toothpaste off of your teeth by swishing in and out. And by pushing the lens, the gold bond lens, in and out, you will force fluid to come back and forth through the hole, and that will dissipate the pigment, get it out of your way so that you can see to apply some more laser. And it will also cause any pigment that's still stuck, iris pigment epithelium that's stuck on strands of iris stroma, to swing into the hole where you can shoot them. So you want to see a gush, push in and out, shoot some more, push in and out until nothing swings into the way anymore, and your view is clear because you've pushed in and out to clear the view. And I call that the shuffle technique, and I don't hear anybody else teaching it, even though it's been published. And you may say, well, how did you think of that? How did you invent that? Well, I invented it back in about 1980 something, 82 or something, because I had a patient with Parkinson's, and they were doing the pushing and pulling for me. And I just simply recognized what was happening and thought, oh, I should do that on purpose. Well, here's somebody, we've made a laser iridotomy and we're still not seeing any angle structures. So what do we have to do? We have to do indentation gonioscopy. And we push, again, lifting as we push so that the inferior third of the mirror is what's indenting the cornea in a regular distortion, not an irregular distortion of just pushing in. And this shows us that here's the iris, and this reverses the pressure gradient across the iris. So the iris is now draped down over the lens, and the lens doesn't go all the way out to the angle. So it should rise back up to the angle. But look, it goes over a little bicycle tire here. And what is that? This double hump sign, the first hump being here and the second hump being there. These are ciliary body processes that have rolled forward. Nobody's born that way. This is something that develops over time, and we do not understand the mechanism at all. But it is progressive in some people. In Miami, it makes up about 2.7% of the angle closure cases that I saw. I did 1,726 cases of laser iridotomy over the first several years that I was in Miami, and we kept track of the ones that had plateau iris because Doug Anderson and I were the only glaucoma people at first, and I saw the cases, and it turned out that 40 of the eyes, or 2.7%, had plateau iris, and this ciliary body processes pushed forward. And I said to Dr. Anderson, I think that the mechanism of this is that the ciliary processes are rolled forward and are lifting up the peripheral iris. And he said, well, I think you're right. You're pushing so hard that this hump is breaking up into little humps that are the shape of the ciliary process, the knuckles of the ciliary processes. Instead of being a straight line, it was breaking up into individual lumps. And we tried to get to use ultrasound to document that, but we didn't have ultrasounds that had high enough frequency to look at structures in the front of the eye, so we couldn't follow through on it. But I thought I had worked out what was the mechanism, at least what was going on mechanically in plateau iris. Still didn't know why it happened. Well, after iridoplasty, where you heat shrink the peripheral iris, it will open the angle. And you have to watch that over the years because it can recur. But the treatment for appositional angle closure in somebody who has an iridotomy, so you've eliminated any pupil block, any pressure gradient across the iris that might be causing it to come forward against the drain, iridoplasty is by far the best treatment in that situation, not taking out the lens. Now, we've had some controversy about this, and I wrote another editorial. But if you, in this case, where the patient's pressure was 28 on nothing, and after the iridoplasty, it was 14 on nothing, and they were cured, basically. I mean, you had to watch them to see it didn't roll, the ciliary processes didn't roll forward in the future. But this is by far the best treatment. Now, if you have a lot of adhesions in the angle, half the angle is closed by adhesions, then maybe taking out the lens is a better thing to do, because the area next to the adhesions, you may form more adhesions. And if you have it completely sealed by, even though you have this plateau appearance, if it's closed all the way around the angle and the pressure is high, you're going to need a trabeculectomy. You're not going to be able to restore function. Ike Ahmed has, in some of these eyes, when he was taking out a cataract anyway, done cyclophotocoagulation inside the eye, laser treatment to the iris processes to shrink them. And that is another way to do it, instead of shrinking with laser applied, argon laser applied from the outside. So the treatment, here's Bob Rich, who popularized the technique of iridoplasty for plateau iris. You're using a 500 micron spot size for half a second and applying it, and then skipping about to 5 spots to the next area. And you'll see you want to have the patient looking away so that you're putting it as far peripheral as possible. And you want to see a shrinking. Don't pay attention to the spot. Pay attention to the tissue next to it that is, you can see the structure shrinking down. And then when you look inside the eye, you see the angle has come open. Now, it turns out that laser iridoplasty was invented 6 months before Bob Rich, was invented by Richard Simmons in Boston, and then was invented by Bob Rich, who popularized it in New York. And neither one of them was trying to do iridoplasty. They had no idea. They were trying with settings, they were trying to do iridotomies in closed angles, and accidentally, without making a hole, with the argon, had shrunk the surface of the iris enough to pull the angle open and relieve the angle closure, and then realized, oh, I guess I could do that on purpose in some other situations. So in plateau iris syndrome and in nanophthalmos, very, very short eyes that get angle closure, iridoplasty can be very helpful. Well, in 1979, this patient from Venezuela came to Bascom Palmer and was seen by one of my predecessors at the Institute, and had what I think you'll all agree is a an adequate surgical iridectomy. Now, we really don't do surgical iridectomies anymore, except in rare cases of uveitis where making a hole in the iris with a laser, it just won't last. It just keeps being covered by inflammatory material, the iridotomy, if you get angle closure. And appositional angle closure, which is the only part you can reverse. And anyway, but this patient came back in 1988 still having angle closure attacks. And so the thought was, how is this possible? And the answer came from looking inside at the gonioscopy, showing the ciliary processes rolled forward, lifting up the peripheral iris. Now, Bob Rich and I used to have wonderful discussions about plateau iris, and he said he thought the lens was involved in this in some way. But I said, no, it's forward rolled ciliary processes. The lens isn't anywhere out there. And I showed him this picture, the ciliary processes lifting up the peripheral iris. I showed it at a laser course we were putting, Al Coker and I and Bob Rich and other people were putting on Max Forbes at the Academy in those days. And here, you see the lens is not part of the problem. The ciliary processes are lifting up the iris. And then here's a direct view of the ciliary processes rolled forward in the area of the iridectomy. Watch what happens when we push on the eye. The processes roll back. See that? Here they are in their natural position. Here they are rolled back. Now, obviously, I cannot create a reverse pressure gradient pushing on the cornea in this eye, a pressure gradient across the iris. What this does is I'm pushing on the eye, which increases the pressure in the eye, and anything you do that increases the pressure in the eye will stretch the corneal scleral ring and pull the ciliary processes posteriorly and open closed angles. And the suction cup of a Goldmann lens does exactly this. And that's why putting the Goldmann lens on can make you miss angle closure, and why putting on the Zeiss, but without any pressure at first, you can see the true situation in the dark. Is this person got appositional closure or not? And then you can push to find out if it's appositional versus synechial closure with the Zeiss lens. Well, here's some wonderful UBMs, because by 1991, about 3 years after I had seen that patient, where I could see what was going on, Bob Rich got together with Ethier, who had a UBM for the anterior segment with a higher, like 100 hertz. Was able to visualize the anterior segment and show, here's a normal eye, cornea, iris going straight from its insertion out to where it sits on the lens, ciliary body processes well behind the iris. That's normal. Here's pupil block, ciliary body not involved, iris bowed forward with appositional closure. Here is plateau iris. The iris is fairly flat, but it's being lifted up by forward rolled ciliary processes here. And then after peripheral iridoplasty, heat shrinking of the tissue in this area, pulling the angle open. So that beautiful demonstration from these pictures sent from Bob Rich. Now, there's another situation to consider where iridoplasty can be helpful. Patient comes in the afternoon, comes in to have an eye exam. And while they're having this eye exam, their pressure's 12, and they're being dilated and looking at the retina for macular degeneration. They come back that night and the pressure is 70. So obviously what's happened is they were dilated, the pupil rapidly expanded, so that when it was in the mid position of dilation, which can cause pupillary block, it went through it so quickly that the pressure didn't build up. But as the pupil came back, slowly getting smaller, got to that mid position that in this particular patient's eye increased the pressure gradient between the posterior chamber and the anterior chamber, pushed the iris forward and caused an acute attack of angle closure. Dr. Grujewski, on our faculty, saw the patient, made a very adequate laser iridotomy, and the pressures, despite medication and the iridotomy, remained 40. Why? This patient doesn't have angle closure under normal circumstances. They didn't come in with it. What happened is when the pressure in the eye is high, above 40, it cuts off some of the blood flow or reduces the blood flow to the ciliary body in the iris, and the ciliary body swells. And when it swells, it can roll forward, closing the angle with what I would call pseudo plateau iris. And so the treatment for it in this case was to do some iridoplasty. You could do this treat this with medical therapy, and very often that's fine. And sometimes you'll do a laser iridotomy and the pressure is still 30 or 40, and you say, well, it didn't come down, angle didn't open, we're going to have to do a trabeculectomy. You come back and see the patient in the morning, the pressure's 8 and the angle's open. Well, you got the pressure down enough that the congestion in the ciliary body went away, the processes rolled back, shrunk back, and the pressure was okay, and you're just really puzzled by that. Well, that was due to this mechanism of congestion, which can also happen if you put a tight scleral buckle on somebody or in an eye occasionally that has a vein occlusion. They may have enough swelling of the ciliary body to close an angle, but that's pretty rare. Well, in this case, as I say, I did a little iridoplasty, a burn a little farther away to deepen the angle focally, and then just a few more spots was enough to get the pressure down in the eye. Now, with anterior segment OCT, you can see the plateau iris configuration in this patient. The angle is not closed. It's open about 10 degrees. You certainly would want to watch this. Now, in Asia, in Chinese eyes, it turns out that about 25% of their angle closure got a plateau iris component. And so some of the studies you'll see from Asia and from the Middle East, the plateau iris is much more common. In Miami, at least, it's only about, as I say, 2.7% of our angle closure cases who got to us that have a plateau configuration. Well, here's some other things to look at. This is Sample-AC line and the heavily pigmented trabecular meshwork in a patient who's got pseudoexfoliation. And here's a patient who has had an injury to the eye, in which case the force of the blow tore the attachment of the iris and ciliary body to the wall of the eye. They move back, and there's some pigment on the zonular diaphragm of fibers supporting the lens here. You can see that as well. That was just knocked off when this tissue pushed back, rubbed some pigment off the iris pigment epithelium onto the zonular diaphragm. And what happens in these eyes often is when you have a tear of the trabecular meshwork is that the pressure may go up right away and you have to deal with it. Or, as David Campbell showed, over years, corneal epithelial cells can grow down over the denuded trabecular meshwork, which was torn during this injury, and cover it. And the pressure can go up maybe 10, 15 years later. That process of the cells growing down over the injured meshwork can then raise the pressure if you have 180 degrees or more of this angle recession. So you have to watch those eyes forever. Every year you're going to need to take a look at them. Here's a patient sent to me by the retinal service at Bascom Palmberg, where they said, this patient is diabetic. They have severe non-proliferative retinopathy, and they have open-angle glaucoma. And the famous retina surgeon who sent the patient to me had not done gonioscopy, but they didn't see any iris neovascularization at the slit lamp. And so they assumed that it was not neovascular glaucoma. Well, it was neovascular glaucoma. And here you see abnormal blood vessels growing across the trabecular meshwork and arborizing as kind of a pink color to the trabecular meshwork. Well, this patient with a pressure of 44 got PRP, panretinal photocoagulation. These vessels regressed. Now, You still have a fibrovascular membrane there, but it's a little more permeable to fluid afterwards. The pressure then was 25, and then I was with Tim Optic, I was able to control the pressure in the eye. But when you have a pressure elevation in a diabetic eye, you've just got, even if it's a deep chamber, you need to do gonioscopy. And you may find that you have early neovascular glaucoma, and doing a panretinal photocoagulation will be very important to improving the situation and keeping this angle from being closed by the proliferation of fibrovascular tissue that eventually can pull the iris up and close the angle. Now, doing laser trabeculoplasty on these eyes doesn't work. And when you fire the laser, what you see is a bubble trapped under a bubble of, you're hitting the aqueous, making it hot, making some steam. You'll see bubbles trapped, not the little champagne bubbles of selective laser, but bubbles trapped under this membrane. And you realize, oh, it's not gonna help in any portion of the angle that it had neovascularization. And this is just to show you that you can do surgery in the angle. This is the old eye stent, where under viscoelastic, Ike Ahmed is putting an eye stent, the old type of eye stent. The new one, you just put straight over the meshwork and push a button. This one, you had a little extension, you had to slide it in. And there he put some trypan blue in, and you can see it now is going out through the aqueous veins and joining the veins on the surface of the eye. And that is it for gonioscopy. So, questions about this part?
Hello.
Yes.
At our department, we have a Goldman lens and a Posner lens.
Yeah, the Posner is a Zeiss type of lens.
Oh, perfect. That's what I wanted to know.
It is awkward for me to use it. The angle at which it comes out is, I don't know whose hand that was convenient for. There are also lenses called, I think is it the Sussman, which is like a Zeiss lens with a rim around it, a ring of plastic around it. They don't make these ones on the tuning fork anymore. I love it because I now have some extra ways that I can bend it, but they're not making it, which is sad. But other questions about gonioscopy?
Yes, doctor. With the part of the gonioscopy lens for surgery and for the practice per se, the difference between them, there are different lenses, correct?
There are. Ike Ahmed has one that seems to be like it stays on, that is good. And there's a bold, VOLD lens for looking at the angle for doing these things and for moving the eye around. It has a handle, the handle on it. And I think, whoever teaches you angle surgery, some of the MIGs, and there will be a lecture on MIGs later on. I will talk later about the Zen and the microshunt because I was very much involved over 9 years working with them and helping them get to the market. And by the way, Juan Valle in the Dominican Republic was an essential feature in both of them getting to the market. Very good research and training can be done in Latin America. Don't sell yourself short. Any other questions about? But I think you're probably going to be using the lens that whoever teaches you to use it uses. But the two major ones are Ike Ahmed's lens and the Bolt VOLD. You can use a Swan Jacobs for that matter, the one that we use for congenital glaucoma surgery. Other questions, comments? Okay. Let's see. Well, let's see. That was like an hour and a half, and we're going for 2.5 more hours. So let's see. I think we can do this one before taking a break. It's how to get your patient to play on the glaucoma team. I'm taking this out of order because it really has so much introductory stuff that things that happen later are explained by it. And it's a narrated MP4. And by the way, any of the stuff I'm presenting here, I can send, I can put in Dropbox and people can have them if they're going to use it to teach. So here we go. Hola, this is Paul Palmberg at the Bascom Eye Institute in Miami, Florida. Here's a view of the world at night from NASA satellites, all many images stitched together. And you can see also the lights of San Juan there in the Caribbean. You see this? The lights of your towns.
Yes. Yes.
Central and South America and the Caribbean, as we're all gathered together over the internet. So closer view. And this year, instead of all gathering in San Juan, we are in our own homes. And let's start off by talking about getting your patients to play on the glaucoma team. Patients really have to be very involved in their own care in most cases of glaucoma. So they need to understand what's going on, why it's important to them, what their role is going to be, what our role is going to be. And so this is kind of as if you were the coach for a football team. You get together these novice players and you have to explain the game to them and what the rules are, how you can tell if you're winning or losing, and put them through some drills so they are trained to do the things that they need to do. So they have to initially go to glaucoma training camp. Well, this really just means a discussion that you have with them or that you give to them after they've seen a video or read some materials that you prepare about glaucoma. You need to understand the nature of the game. This is, and we'll go through some of the simple facts that need to be transmitted to them. And we have a scoring system here. We can watch and measure the optic nerve. We're very fortunate in ophthalmology and in glaucoma that we can measure the tissue that's involved in the disease and measure it to see if there are some focal losses, and we can follow over time to see if things are getting worse with the tissue. And we can also test the function, provided that the patient is good at taking visual field tests, which we'll have to train them on. And then we have to develop a winning plan for each condition of the field, in this case, the visual field rather than the football pitch. And as I say, drills, such as teaching patients how to take drops and making sure that they have a plan to remind themselves how they're going to get their drops, how they're going to take their drops if they're taking drops, and make sure that they have a way of keeping appointments and that our offices are set up to recognize when appointments haven't been kept so that the patients can receive reminders. Having people not fall off the team is really important. And good players are going to overcome glaucoma with good compliance, adherence, persistence, which we'll talk about. Well, what is glaucoma? Glaucoma is a disease of the optic nerve, the nerve that carries electrical signals from sight to the retina, from the retina to the brain. There are about 100 million photoreceptors that are connected together through bipolar cells and horizontal cells. And the information coming from the retina is already pre-processed in many ways, not just to give a point-by-point representation of vision, but also to detect motions, detect edges, colors. And all of that information then is transmitted by about 1 million on average ganglion cells, and their axons gather together at the optic nerve where they leave to go out to a relay station in the lateral geniculate ganglion and then on to the areas of the brain where we see. Or you can give a simplified explanation of that to patients. The exact cause of glaucoma is not known, but usually glaucoma is associated with a higher than average pressure, not necessarily a higher than the normal distribution of pressures inside the eye, which can either, one, reduce the blood flow that nourishes the nerve where it exits the eye at the optic nerve head, or two, stresses axons and their supporting astrocytes by having a pressure gradient from the inside of the eye to the pressure on the other side of the wall of the eye. So what is it that damages the nerve in glaucoma? The pattern of loss tells us that the site of damage is at the optic nerve head. Detective work suggests that that's the only site that can explain the patterns of loss in glaucoma. And a likely mechanism is a pressure-related blockade of exoplasmic transport. This was first demonstrated by Douglas Anderson at Bascom Palmberg in 1974. In monkeys who had been treated with extensive laser to the outflow pathway, the trabecular meshwork, not in a beneficial light application that actually is a treatment for glaucoma in humans, but a very heavy treatment that was damaging to the trabecular meshwork, keeping fluid from getting out and therefore raising the pressure. And then he gave radioactive amino acids in the vitreous cavity, which were incorporated into the ganglion cells and sent down the axons as part of the normal turnover of proteins in the axon. Why those radioactive amino acids now in proteins lit up on radiotography right at the optic nerve head, not before, not after. There was a traffic jam there. And that blockade helps us to see again, where is the site of damage that's taking place in glaucoma? Now, where does pressure come from? What's the story behind that? Well, the eye pressure depends on the amount of a clear, nourishing fluid that's transferred into the eye by a tissue called the ciliary body, which is a circular tissue. We're seeing it in cross-section here above and below the lens. And it pumps into the eye all of the amino acids, the sugars, the lipids, the minerals, the vitamins, and growth factors that are needed to nourish tissues inside the eye. And they flow into the posterior chamber around the lens. And then they move by a pressure gradient over the surface of the lens, nourishing it because it has no blood supply. It has to be fed by this aqueous humor through the pupil into the anterior chamber to feed the cornea. And then that fluid passes circumferentially towards the periphery of the anterior chamber and leaves via the trabecular meshwork tissue in the angle and out through a canal, a circumferential canal, Schlemm's canal, and then on up through collector channels to the surface to rejoin the circulatory system in small veins on the surface. So the fluid is produced, and the pressure in the eye depends upon the production of the fluid and also upon the resistance to the exit of the fluid at that drainage angle. And in primary open-angle glaucoma, there is an accumulation of chondroitin sulfate associated with the trabecular cells there, as Paul Nepper and I published a few years ago, and a reduction in hyaluronic acid. The cells from that region, from donated eye bank eyes of glaucoma patients, had some biochemical abnormalities, that the cells were alive but were at senescence, and like many aging cells elsewhere in the body, their associated glycosaminoglycans included chondroitin sulfate and a reduction in the amount of hyaluronic acid. So why that happens, we don't know. There are many types of glaucoma, each named for special features. For example, one of the main ones is angle closure glaucoma, when the iris is pushed forward by a pressure gradient and closes over the trabecular meshwork. Neovascular glaucoma, in which abnormal blood vessels grow over the drainage angle. Pigmentary glaucoma and pseudoexfoliation glaucoma, conditions where abnormal pigment and material clogs the drain. And steroid glaucoma, where topical corticosteroids applied to the eye can result in a reduction in the turnover of the glycosaminoglycans in the trabecular meshwork and a buildup of pressure similar to primary open-angle glaucoma, but reversible if the steroid is removed. Most of these are chronic conditions which can be treated but not cured by lowering the eye pressure, which will, similarly to primary open-angle glaucoma, prevent additional loss of sight. Some people have an elevated eye pressure, on the other hand, but not yet any nerve damage, a condition called ocular hypertension. These persons require monitoring, and sometimes treatment is a good idea if the risk of developing glaucoma damage is high enough. A very long-term 20-year study of such persons has recently been completed and has identified risk factors which are important, and we'll be discussing that in another lecture, helping to decide whether or not treatment is indicated. But certainly the risk is high enough, by 20 years being about 30%, that these persons require monitoring for sure to see if any damage is developing. And the Glaucoma Foundation has nicely illustrated information available at glaucoma.org, to which you can refer your patients in order to have some material they can refer to. Let's go on to the scoring system in this glaucoma team. And first of all, we are interested in measuring the structure of the optic nerve. We're quite fortunate in ophthalmology that we can see the tissues that are involved in disease. And in the case of the tissue of the optic nerve, which when ganglion cells are lost, the amount of ganglion cell tissue at the optic nerve, and also an area where the ganglion cell layer is quite thick in the macula, these can be studied with optical coherence tomography, a laser interferometer, and it shows us the structure with a 4-micron resolution of the nerve fiber layer. And we do know, though, that retinal edema will also make that tissue thicker, so we have to be careful in diabetics, particularly in the macular region, when we're interpreting the numbers. However, this approach to measuring the tissue of the nerve has a huge advantage compared to previous methods, in that it can also be used to monitor macular disease in age-related macular degeneration and diabetic macular edema. Those other procedures which were popular are GDX, or laser polarimetry, which looked at the optical rotation of light generated by the structure of the nerve fiber layer and the retinal tomography, so-called HRT, which use confocal reflectance from the surface to measure the shape of the tissue, which had about a 12 micron resolution. But it has been so outperformed by OCT, which measures actual structure rather than just the shape of the surface, that it's really become obsolete. Now, in addition to measuring structure, we are interested in measuring the function of the optic nerve. And at the present time, standard automated perimetry, which will be discussed in other materials in this course, is the way to go. There are computer controlled testing parameters, algorithms that can measure the sensitivity of various areas of the retina to light. And there are some experimental ways: frequency doubling perimetry, short wavelength perimetry, and the pattern electroretinogram, but they are currently mostly involved in research. Well, what's lost first in glaucoma, structure or function? Well, clearly, function is lost first, but our ability to, because a cell may lose its function without dying, but it can't die without losing its function. But curiously, because there is perhaps a multiplicity of wiring between the photoreceptors, or perhaps because you have to lose so many ganglion cells in an area before we can detect a change in function, it turns out, curiously, that structure, by the techniques we have, is usually measured first. This was reported in the 1970s as generally showing a loss of tissue before a loss of field. And this led to a mythical paradigm that this was always so. And Dr. George Spaeth is one of the first to publish on this, along with Dr. Alfred Summer and colleagues at Johns Hopkins, Dr. Shioshi in Japan, Dr. Grant and Burke in Boston and Harvard. And this was updated by Harry Quigley at Johns Hopkins and Robert Weinrib at University of California, San Diego, in which they were doing quantitative methods of measuring visual field and measuring tissue. And the thought developed that once vision loss is detected by visual field, that structural damage has already occurred, and that Quigley has said patients may lose up to 40% of their optic nerve fibers before damage can be detected by fields. Well, that was with older methods of visual field testing. I would say now it's not likely you would lose more than about 10% as a change. And also he has said that up to 90% of the nerve fibers could be lost before patients have symptoms, and that unfortunately is true. Well, the consequences of adopting this myth, the good consequence is that it brought a proper attention to looking for structural change by examining clinically the optic nerve and recording with photographs or with these newer methods of measurement what was going on. But it also led to an inappropriate aggressiveness with medication, even surgery, to treat ocular hypertension before there was any detectable functional loss, for fear of losing half of the optic nerve and fear that once damage occurred, it would be difficult to halt progression. But we now know that with sufficient lowering of intraocular pressure, it may be harder to stop the damage, but we can stop the damage in virtually all patients, as I will show you in a following lecture. And with OCT and photos, we can detect perhaps a 10 to 20% change from baseline, allowing ocular hypertensives to safely be followed without having to be very aggressive. So it ain't necessarily so that you're going to lose structure before function. And there have been 3 tests: the ocular hypertension treatment study, Chauhan's longitudinal study in glaucoma patients, and Hayworth's monkeys that he trained to take visual field tests and do very accurate visual field tests. Amazing. They look just like the visual field tests taken by cooperative adults. Well, in the ocular hypertension treatment trial, treatment with Timoptic, a beta blocker, reduced the intraocular pressure by about 20%. In the patients who were randomized to treatment, about 4.4% of them converted to detectable glaucoma versus 9.5% by 5 years in people who were just being observed carefully without treatment. And no one went blind. The amount of damage that took place was actually quite mild at first in those patients when they were detected and then treatment was started. Unfortunately, however, by the time we got to 20 years in the trial, there were some people who had suffered rather substantial losses of vision. And it's a little disconcerting that even under observation, they had not been prevented from losing a lot of visual field. And it's going to be analyzed to see what factors were they. Were they just not treated quickly enough? Were they not treated aggressively enough? Or were the treatments, including surgery, simply not successful? And we'll need to see as those results come out. But in that study, interestingly enough, 55% of the cases were first detected only in stereodisc photographs of the patients compared to their baseline stereodisc photographs detected by a reading center. And 35% were first detected only in the visual field. And only in about 10% did both of structure and function be found to have progressed at about the same time. In established glaucoma patients, Dr. Chauhan and his group in Dalhousie University in Canada explored the same question and found following visual field with standard automated perimetry and perimetry that about 2/3, when they changed, had structure change first and about 1/3 function first. And curiously, there was little correlation. And as I say, perhaps there's a redundancy of wiring in the retina that hides some loss of function of dead cells. Perhaps 6 cells malfunction without as yet dying on the other side. And then the third test where it appeared that you were losing cells before a loss of function was in Harworth's monkeys, which, as I said, were able to perform automated perimetry quite well when you gave them little squirts of orange juice as a reward. And you see this curve in which the ganglion cell loss goes from 10% to 50% with very little change in the sensitivity loss in the retina. And this led to the thought, well, looks like they're losing structure without function. But that's a complete misunderstanding of what really happened. Notice that whereas normally in these monkeys, their sensitivity loss is 0, you already have a loss of 6 decibels. Remember that 3 decibels represents a 50% loss of function. You already had about 6 decibels of loss immediately by the raising of pressure to about 40 or 50 millimeters of mercury in those eyes. So really it was function that was lost before the cells died. So here you had a lot of non-functional cells, and then they start dying. And it's only later that both of these losses increase. So this has been misinterpreted entirely. It's really, in this case of a sudden rise in pressure, the function is lost before cells die. Well, let's think about how these are used. Here's a patient with ocular hypertension, pressures of 24 and 22, normal corneal thickness, and the corneal thickness can affect the measurement of intraocular pressure and has been shown to be a risk factor of the thinner the cornea, the higher the risk that an ocular hypertensive patient will go on to glaucoma. And this is someone in which the cup-disc ratio, that is the unoccupied area in the middle of the, shall we think of it as a donut of tissue, of nerve tissue at the optic nerve, there is usually an unoccupied central region at the optic nerve head. And when the vertical area of the cup in the center of the optic nerve head is has half the distance as the diameter of the optic nerve head itself. That's a cup-disc ratio of 0.5. That could be normal or it could be abnormal depending on whether someone was born and developed that way or whether there had been a loss of tissue resulting in an enlargement of that cup-disc ratio. And in this patient, the Humphrey fields were entirely normal. But what would an OCT show in this person who does have elevated pressures and a family history of a mother with glaucoma? Well, here's the nerve. There's a good orange rim of ganglion cell tissue here at the nerve. There's no vertical elongation of the cup as frequently happens in glaucoma because there is generally a selective loss of tissue at the poles where the tissue is thicker. And in the other nerve, maybe this cup-disc ratio is slightly larger, but again, there's a good rim of tissue and there's no focal loss that would tell us of glaucoma. Now, this patient also happened to have a condition called idiopathic central retinopathy, and that's incidental. That has nothing to do with it. And we don't see any loss of nerve fiber layer sheen above or below the disc in either arm. And so what about the visual field? These were entirely normal. And in fact, for the age of the patient, she actually was performing slightly better than the average. Now, these are the points at which the threshold for just being able to detect light were tested in a random order by the computer. There is a spot you don't see, which corresponds to the optic nerve head itself, where there are no photoreceptors, and that should show up here. But it was completely normal. There were no significant depressed points in the visual fields, and so the computer said within normal limits. What about the OCT? Well, the OCT showed that there was some thinning superiorly and inferiorly in the right eye, and some superiorly in the left eye compared to age-matched controls. Now, the measurement is made out around the optic disc at about 3.4 millimeters from the center in order to, it should then therefore have about an equal distribution in eyes with large and small cup-disc ratios. You're measuring it far enough away from the nerve that it should be the same. And in this case, there was a reduction in the amount of tissue compared to statistical normals. Now, if this green area on the plot as you go around the nerve corresponds to 95% of the people in the population, and the yellow corresponds to 5% of normal people, and then the abnormal the red should only be seen in about 1% of normal people. Now, you might say, well, how can normal people have fewer? But during development, we all had about 2 million ganglion cells that sent their axons out to make a connection to the brain. And during development, those that successfully gathered at the optic nerve head and grew on out to make proper connections at the lateral geniculate, why they stayed around. And the ones that did not successfully make such a connection committed suicide. They had apoptosis, is the mechanism. And so normal population people who don't have glaucoma can have anywhere from about 750,000 to about 1,250,000 nerve fibers. And so you could have in a normal person, in normal people who didn't have glaucoma, have not lost any since development, you can have fewer cells present, and therefore there is a distribution of thicknesses in the population. And this is why there's an overlap in the mean amount of tissue at the optic nerve between people with glaucoma and those with early glaucoma.
I'm going to pause for a second to point out that the signal strength in this patient was a bit low. So that may account for part of it, things looking worse. And also that in some people, if the disc is tilted, the peak amount of tissue may be offset. And you really would have to think about moving this peak over, and comparing it to the distribution in normal people. But nevertheless, this amount of total thickness, the average thickness, was abnormal for this patient.
Started out with a normal amount and then got less, you would then come to the yellow region, for example, and then to the red. But if you started out with fewer, you might have started out in the yellow zone, have quite an overlap with normal people. And so you can't make a diagnosis of glaucoma just because one of these regions might be yellow, although you'd be suspicious. But when the loss is focal, and particularly when it's focal above and below, that's highly suggestive of glaucoma. Focal loss is not what you see in those people who have various amounts just due to how things developed in their eye. Now, we now use spectral domain OCT, which does not just measure the nerve fiber layer in the circle, but rather measures a cube of tissue in 3 dimensions. And then the thickness of the tissue is represented in these colors. And as you can see here in someone who has glaucoma in the left eye and not the right, the tissue, which is thicker, indicated in this case in red and yellow than the areas where it's not as thick, why that's washed out here somewhat on the left side. So this person who has 105 microns average nerve fiber thickness around the nerve is reduced down to 65 in this person. And one of the important things about reading these is that the test has to have a high signal strength in order to have confidence in it. But in this case, the signal strengths were high enough, and they, on a scale that goes up to 10, they should be 7 to 10 with this particular machine in order to have confidence in the values. So when is OCT a help? It confirms damage in a patient with a borderline field. It's good for monitoring the nerve status in patients whose fields are not reliable. You have to depend on looking at structure. And to detect damage not evident on fields or even by looking at the nerve yourself. And to tell whether damage is present when a large cup or asymmetry could be physiologic. Some African American, particularly persons, have rather large optic nerve heads. Now, if you were making bagels and or donuts, and you had the same amount of dough, but you just
spread it out more into a larger diameter donut, why the hole in the center would be larger as well without having lost any of the dough. And in some patients, they can have a cup-to ratio as much as 0.8, but a completely normal amount of nerve fiber layer. And the OCT machine is very good at helping to rule out that there has been a loss of tissue in such patients, particularly when they're fairly young and they have normal pressures in their eyes and their visual fields are completely full. So studies of OCT in normals, ocular hypertensive glaucoma suspects, and glaucoma patients show substantial overlap in mean values. And that limits the value in diagnosis just on the mean values. But it's certainly essential for monitoring for change and for focal loss, which can be diagnostic, or asymmetry between the two eyes, which can be diagnostic. Well, let's go back with me to the 1970s when I was being trained. Hard to believe that's 50 years ago. And how were we doing at that time in treating people with glaucoma? At that time, the majority of glaucoma specialists imagined that glaucoma was like diabetes or high blood pressure, that if you could get somebody into the normal range, that you were probably, if you're getting them in the normal range, you were probably doing as much as you could to benefit them. If you were treating diabetes, you'd be delighted to get somebody to the upper normal range of hemoglobin A1C, for example. And with blood pressure, most of the benefit in preventing heart attacks and strokes is achieved by getting to the upper limit of normal, although that seems to be changing for some high-risk people. They're realizing that even getting down towards a little bit down towards the middle of the normal range can be beneficial. But at that time, it was thought if we just take somebody with glaucoma whose pressure is, say, 26 millimeters of mercury, and the general population has an average pressure of 15 millimeters of mercury with a standard deviation of 3, why 2 standard deviations each way would then give you a range of normals between 9 and 21 millimeters of mercury. So it was generally believed if I took somebody with a pressure of 26, then I reduced it about 30%, 20 to 30%, got it down to 18, that might be as good as you could do. And that if somebody still got worse in the normal range, probably the majority of people would just think, well, there's something else wrong with that optic nerve. It's getting worse. We've done as much as we can do. But that isn't necessarily so. It's possible that if we took the pressure even lower, it would be of additional benefit. But that was an unresolved matter then. We now do have answers about that, and I will be going into that in talking in the next lecture about the coming paradigm shift in glaucoma management. Well, how were we doing? How are things turning out? Well, during the decade from the 70s to the early 80s, Hart and Becker in St. Louis, where I trained, Hart went back and quantitative Goldman visual fields and found that 73% of patients being treated at a major glaucoma center were significantly worse in 10 years of follow-up. Chauhan and Grants found just about the same rate per year of people getting worse. And a follow-up study at Washington University in 2001 still found, more than 10% of people, about 10% of people were getting worse per year on average during 5 years of follow-up. So a bit disappointing. Well, that's visual field progression. Things are getting dimmer and foggier. But what about blindness? A study done by Hattenauer at the Mayo Clinic found that 12% of eyes of glaucoma patients became blind in 12 years of follow-up, legally blind. And at the Royal Leicester, this is really weird English language going for you, the Royal Leicester Clinic, it was reported in the year 2000, 34% of the patients who had been followed for 20 years or more there had become blind. So that's a little disappointing. You, of course, what would the natural history have been if you were being able to compare it? How much better than the natural history were we doing? But my conclusion, at least, was that the goal of having pressures in the upper normal range had yielded disappointing results, and I wanted to know if we couldn't do better if we got even lower pressures. And as I say, that will be discussed in the next. Well, if exoplasmic transport blockade is due to faulty autoregulation of optic nerve blood flow, that's a possibility. And some people, as Dr. Douglas Anderson showed in Miami years ago, if you raise the pressure with a suction cup and then look at the blood flow in the central retinal artery, there is an auto-regulation of blood flow. That is, you raise the intraocular pressure, the blood flow did not fall until you got, in normal people, up to about 40 millimeters of mercury, and then it would fall rather precipitously as you increase the pressure. Of course, this was only held in place for a very short period of time, and then here were the recovery points. But about 10% of the population, he found that there was faulty autoregulation starting right away, and wondered if perhaps faulty autoregulation was taking place in people who have glaucoma. That would make some people much more sensitive to rises in pressure in the eye than other people. And you know, that's a possible explanation. Now, why they would have faulty autoregulation that would be part of the problem of responding to elevated pressure, we still don't know. But it does suggest that for such people, we might be able to compensate for it by reducing the intraocular pressure to venous levels, which is about 8 to 12 millimeters of mercury. Now, it would not be expected to benefit any further by lowering the pressure lower than that, because the blood goes from arteries into capillaries to feed the tissue at the optic nerve, and then would go to veins. And so you're not going to increase the flow if you've already taken the pressure in the eye down to the venous level. Then the limit on increasing flow would then be the venous pressure level. So it's also worth thinking about that the pressure gradient across the optic nerve, if the problem is a pressure gradient, they're pinching axons as they pass out of the eye, that also would predict that a pressure of 8 to 12 might be optimal even for the most sensitive eyes sensitive to pressure, because the pressure on the other side in the cerebral spinal fluid pressure around the optic nerve on the outside is about the same as the venous pressure level. So this would be unlike diabetes or systemic hypertension, as where we said upper normal is optimal. So why would anyone need a low normal pressure? Epidemiologic studies suggest that only a third of glaucoma damage is associated with an excess pressure distribution in a European-derived population. Yet they suggest that the lower the intraocular pressure, the lower the prevalence of glaucoma. And thus, intraocular pressures near episcleral venous pressure may compensate for whatever else is wrong in glaucoma by improving blood flow to the optic nerve or equalizing the pressure gradient across the lamina curvosa, as we just said. Now, Dr. Anderson's study was done on the central retinal artery, but it has generally been thought that the blood supply to the optic nerve head is actually from posterior ciliary vessels. So we don't have similar studies that can easily be done there deeper in. But as I say, in a subsequent lecture, we will show that clinical trials indeed reveal that nearly all glaucoma damage is pressure dependent, and that progression, if you successfully lower the pressure, can be halted, and halted for many years. Well, let's talk a little bit about medical therapy for glaucoma. You're going to have to teach your patient as they get on the team. Should you decide to start with eye drops, very often the first drugs are prostaglandin analogs, Zalatan and the other drugs, and beta blockers, such as timolol. These make up the majority of medications. And then also we have topical carbonic anhydrase inhibitors and alpha agonists. Now, either a prostaglandin or a beta blocker should be the base drug to start out with, because they have 24-hour action. And the other drugs have peak reductions in pressure, but their trough effects are quite small, and the duration of action is not very long. And so one would almost always start with a prostaglandin or a beta blocker, unless there turned out to be some problem with them. There are some systemic contraindications, such as asthma, with beta blockers. You could then add these other drugs. Now, these are the effects of the drugs, the percent reductions, if they are the only drug being used. As you add second drugs to first drugs, you don't get a thoroughly additive effect. In fact, you usually only get a third to a half of the usual effect of the second drug. Nevertheless, it can be useful to add them. Now, what can you expect? Well, if what you want to do in somebody is, let's say they start out with a pressure of 26, as was the case after washout of any previous treatment, in a study called the XLT study that Dr. Parrish and I wrote up, where there were a large number of subjects in each of the three groups receiving each of the three prostaglandin analogs in a randomized mass study. If your goal was to take them from 26 down to, say, 18 or so, why, you could probably accomplish that about 2/3 of the time. But if this is somebody that you thought you needed to get down to 13, 14, or 15, then your chances of getting the pressure down there are only something like 11 to 27%. And therefore, it's important to explain to patients that the initial medical treatment is often only going to get partially to the goal. Now, we explain to the patient, you have glaucoma, we need to lower your pressure, and we have set a goal of, let's say, whatever it is. And we're going to start with a particular medication, and the chances are, let's say it's somebody I want to get to 15, the chances are really only about a quarter or a third that all by itself, this is going to be good enough. So let's start out with it, just in case you're one of the lucky ones for whom this is enough, that we could just stay with the simplest treatment. But there's a good possibility that we'll need to add more medicine. Now, if you don't say that to somebody, and you start a medication and they come back, and then you say, well, that's not good enough, I got to add something, that hurts the confidence of the patient in the whole process of treatment and in you. It's good for people to have realistic expectations whenever you're going to do something for them, so that they understand if you need to go on to the next step, that's not a surprise, not a bad surprise. Patients do not like bad surprises. It's really a confidence breaker. So please explain that this is being tested to see if it's going to be enough, but that, and looking at this kind of table, and depending on what pressure the person started at, you'll have some idea what you're likely to accomplish. And if you think you need a 30% reduction in pressure, you might get that, something like 60% of the time.
But if you feel that you need a 40% reduction in pressure, it's going to be perhaps only about a 30% chance that you're going to be able to get the pressure down that much. And so this kind of information can help you to have realistic expectations and to share them with your patients. So there's a challenge in motivating patients to control pressure because glaucoma is asymptomatic, it's chronic, it requires long-term therapy. They can't see any improvement while they're taking the medicine, and they may have some irritation, and of course it costs money to be treated. So they need to understand that if they're not treated, there is a serious risk of the vision steadily getting more foggy and later dark and foggy, and that it's really important to avoid further loss of vision. And that this is a lifelong disease, so that we're going to have to work together on it, but that if we do it together and we reach the goal, that you don't have to lose any vision or lose any more vision from glaucoma. So what are the kind of barriers that can to successful treatment take place? Well, compliance is important. This is the extent to which a patient takes the prescribed medication. Yes, I'm taking my medicine. Adherence has to do with the patient administering the medication the way it's supposed to be taken. If it's twice a day, they're taking it twice a day, about 12 hours apart. If it's once a day, like a prostaglandin, it's best taken in the at maybe the evening meal time or bedtime, that they are doing that, taking a drop and getting it in and doing it at the correct time of day. And then there's persistence, that they kept taking the medicine regularly and didn't fall off the treatment plan. So this is compliance, adherence, and persistence defined. Well, how good is compliance? Now, back in the 1970s, a brilliant physicist named David Meltzer, MD, PhD, who, by the way, in his earlier career had been an astrophysicist and had written a paper predicting the existence of pulsar stars, and his PhD thesis is quoted by Hanisch, who won the Nobel Prize for detecting pulsars. But Dr. Meltzer decided to go into medicine, fortunately, and I was able to pick him for the residency program in St. Louis, thinking he could probably accomplish a lot as an optical physicist. Well, he designed, and this is back nearly 50 years ago, an electronic monitor in a bottle, and put it into a bottle. It had a microchip that he had sent out to be laser etched, and it had a mercury switch in the cap. So when the cap of the bottle was taken off and the bottle turned upside down, it would record the day and the hour at which that was done. And then the patient would bring the bottle back after a month, and you could look to see the percent of prescribed doses which were taken. And it turned out that subjects averaged taking 76% of prescribed doses. Now, the subjects, if they were asked, claimed 97%. 6%, unfortunately, took less than a quarter of the drops, and 15% took less than half. So that compliance, even in a short term, like 1 month, was not always optimal. It'd be wonderful if we had such a monitor available now, so that we could, in fact, find out how well patients are doing in taking that bottle out and trying to put the drop in. Another surprise of their study was that doctors can't guess the compliance very well. They had the doctor estimate what compliance would be like, and then they had the bottle to tell you. And it turned out that ophthalmologists estimated that 92% of drops had been taken versus the actual 76. And there was a very poor correlation between what the ophthalmologist predicted and what was
actual. The ophthalmologist usually thought that the college-educated person, serious, well-dressed looking person, was probably very compliant, and that the laborers or those with less education might be less compliant. It turned out that actually those sorts of things were not very predictive of who indeed was compliant or not compliant. There's also a problem with persistency. If you look at pharmacy refills in people who are in plans that provide their drugs, so it's not a matter of money, you'll find that at the time of first refill, there is often a people don't follow up. There's about a 30% loss of people early on who just get busy with other things or lose confidence, something happens that they stop taking their medication as much as you would hope. And the same thing is true with statin medications for high cholesterol. This is a typical problem, and this is from drug refill information from large managed care organizations. And if you get the therapy to be more complicated, it also has an adverse effect on the compliance. You make it more difficult, people get, and this has been studied, and it appears that the compliance falls off as you prescribe more medications or more often taken medications. And these are patients who are, elderly generally with glaucoma. They take systemic medications as well, as Alan Robin has shown, majority of patients are taking one or two other medications for blood pressure or cholesterol or something, for diabetes. And so they're having to deal with a lot of complex medical treatments. So we want to take a glaucoma history, a personal and family history of glaucoma. Have there been people with high pressure? Particularly, there have been people with blindness. Has there been a history of eye injury? Because an injury to an eye that damaged the outflow drain of the eye can 20 and 30 years later result in glaucoma in that eye. And people who develop that kind of glaucoma late after trauma are about 3 times as likely to later have the pressure go up in their other eye, perhaps suggesting they were destined for glaucoma and the injury caused the injured eye to get there first. The prevalence of glaucoma goes up with age, of open-angle glaucoma. And so the majority of people present in their 50s, 60s, and 70s. Are there other ocular diseases? Is there eye medication use, particularly steroids, or systemic steroid use? Are they having visual disturbances or eye pain? And quite high pressure can cause eye pain, and even to see halos around lights if fluid is pushed into the cornea by the high pressure. Is there a history of diabetes? And do they have systemic conditions such as asthma or cough, shortness of breath, chronic obstructive pulmonary disease, for which a beta blocker could be contraindicated, or an irregular heartbeat, some of which would be helped with beta blockers, some would be hurt, or heart failure. Similarly, beta blockers may be beneficial or contraindicated depending on the type and what medications they are using that might interfere. It helps if you are in a country where there is a standard for color caps corresponding to medications, to give patients a written list of what they are to take and to color code it. So in our country, COSOP comes with a blue cap, and we can say COSOP twice a day at breakfast and the evening meal, and say Zalatan daily at the evening meal, and also to wait at least 5 minutes between drops if they in the same eye, and then giving them their appointment day and time written. So we have our computer system of medical records print out instructions at every as every patient leaves. Now, this bottle cap system in the United States, at least for the major companies, the color coding goes on in more detail. Now, at the time in 1980, Lee Duffner, an ophthalmologist in Hollywood, Florida, who was a graduate of our program and attending at Bascom, was on our pharmacy committee, and he and I were on the therapy committee of the American Academy about 1980. We already had pilocarpine with a green cap, and recently introduced had been yellow Tim Optic 0.5% and blue Tim Optic 0.25. And he made the suggestion that we set aside orange, purple, and teal for future glaucoma drugs. And they became teal, it became the prostaglandin analogs, purple became the alpha agonists, and orange became the topical carbonic anhydrase inhibitors. It also set aside gray to be non-steroidal anti-inflammatories, brown for antibiotics, and pink or white for corticosteroids. Now, unfortunately, generics don't always follow that in the United States, and other countries don't always use this system. So you would want your patient to bring in the bottles that they get, so that when you're giving them a color coding system, you can actually match it up to what they have by the bottle caps. And as I say, these are the color codes that we have in the United States. Plus, we'd already had red for dilating drops in addition. So how to apply eye drops? There's a way of doing this that I will illustrate for you. Most people try to take a drop as if they were applying, as if they were drinking water. They take the cap off the bottle, and the cap is, the tip of the bottle is upwards, and then they turn their hand over. Well, that makes it tough to get it to the eye, because you could be off to one side or the other very easily. You're not quite sure where your hand is. But if you pull down your lower eyelid to make a sac to receive the drop, and then if you blink, by the way, it won't close the eye completely. You're not going to have the drop hit the lid rather than the target. And then grasping the bottle with a finger and thumb upside down. And with the well-made drops, if you turn them upside down, the drops don't fall out. You have to actually squeeze it a little bit. They have a constriction near the opening of the bottle. However, some inexpensive generics from other countries, you can't turn it upside down because it would run out. But for those that don't, you hold the bottle like this, you're pulling down, and now you rest your palm on the knuckles of the first hand, or these knuckles can be on your own cheek. And then as you squeeze the bottle, there's just no way to miss putting in the drop, because you've used contact of the hand with the face to know where your hand, where the bottle tip is. And that can be very important if the eye has very poor vision and can't even see the bottle coming. This also is beneficial that the drop's going to fall in here, because the patient doesn't really even have to look right at the bottle, which could be a little, make them try to avoid it. And then simple eyelid closure, or compress the nasolacrimal ducts, and waiting 5 minutes or more between drops so that the medicine has time to be absorbed before the next drop might be put in the eye. Now, the normal tear flow is going to flush any remaining drop out of the tear film within about 5 to 10 minutes, so there's no need to wait longer than 10 minutes. And simple eyelid closure works quite well in preventing the fluid from leaving the tear film and going down the nasolacrimal ducts into the nose. And this might be important for beta blockers if you don't want them absorbed, or for topical carbonic anhydrase inhibitors, which if they go down the nasolacrimal duct into the nose, they will spread on in the moisture inside the nose to the throat, and they will taste a bitter taste. And that can be avoided by simply keeping your eye closed until the normal tear flow rinses the drop out down your cheek after about 5 minutes. The alternative is to try to press over the nasal lacrimal ducts, but it's just as good to let your eye be closed, and many patients don't do this successfully because they're not really pushing over the nasal lacrimal duct. And if the person flinches and squeezes their lids at the time of applying their hand, they'll actually be pumping the fluid out of the eye. Blinking is what pumps fluid out of the eye down the nasal lacrimal duct. So they should just let their eye fall gently closed to prevent pumping the drug out of the eye into the body if that is important. So when the patient comes back, you want to inquire at the follow-up visit, what drops are you taking and when? Please bring your bottles and bring your instructions so we can go over it. Are you having any trouble remembering to take the drops? And if so, those people that have iPhones or some kind of smartphone can put reminders into their phone that will go off and remind them to take their medication. That could be a big help. Or they can take them at the same time as meals. So alarms or meals can be very helpful until the habit is fully established. And are the drops causing you any discomfort? Some people will develop red irritated eyes with prostaglandin analogs. Or do you have any new medical problems? I was called one time by a hospital saying the patient has been admitted to the hospital and they want to make sure they keep taking their drops. I had just put the patient on a beta blocker, and I said, well, why are they in there? And they said, well, they've developed a congestive heart failure. I said, well, then I need to talk to the doctor because maybe my new drop that I've added is really the problem, and we wouldn't necessarily want them to continue to take it. Or if someone were to develop asthma, adult asthma, or a chronic cough while taking a beta blocker, you want to know if there are any related medical problems. And are you running out of the medication? Are you having trouble remembering to refill? And now that we have electronic systems for ordering medication directly to pharmacies, including a year's worth of refills, this is happening less often. Is cost a problem? Some of the drug companies have provision for providing free or reduced cost drugs to patients. And if they just simply can't afford it and can't get it in any way, you may want to go to laser trabeculoplasty, which a recent study from the United Kingdom suggested might be a better initial treatment anyway. The problem with laser as initial treatment is that patients can get the idea that it's cure. And they didn't understand that if they have that, even if they don't require any medication, that they still have to follow up at the same, at the appropriate intervals, because laser treatment usually will not last more than 3 to 7 years, and you don't want to miss it when the pressure goes back up. Very important to emphasize that. And do you need someone to put the drops in? You've got Parkinson's, or you have arthritis in your hands. You may need somebody to put it in for you, and we need to arrange that. And having the patient try to put the drop in themselves in the clinic often gives an opportunity for say a daughter or son of the patients to recognize that they're not able to put it in, and they'll say, well, I'll be sure to put it in for them. So that's important. And do you need somebody to help remind you to take them, to help put them in, or to help go get you your refills? You need to have a plan that's going to work. And then recognize that if memory gets worse, patients get other diseases, physical disabilities, this can affect their ability to follow through. Major life events. Sometimes I've seen somebody come in with a pressure out of control, and they said, oh, well, my daughter was very sick, and I was worried and working with the doctors on it, and I just forgot to take my medicine. Or travel away from home. People need to be encouraged. Be sure you have a bottle that you're going to pack and take with you if you're going somewhere. Any change in routine, moving from one house to another, can disrupt people's ability to take patient. So I've already mentioned all of these things about cost and complexity of the treatment, and changes in the regime really need to be quite clearly stated and on written instructions. Systemic medications. There are numerous warnings on over-the-counter and prescription medications, either for bladder treatment or for cold medications, and they have warnings about not being used in glaucoma patients. Well, those warnings on anticholinergics really only apply to pupillary block angle closure glaucoma, and if someone has those problems, we either treat it with a laser iridotomy or taking the lens out of the eye, and so the number of people who would still be affected by taking these medicines is an empty set. There really shouldn't be anybody for whom these warnings apply. And we've tried to tell this to the companies that make these medications. Take that warning out. People are not getting the benefit of your drug because they have a history of glaucoma, and they're not going to be harmed. It's not going to interfere in their glaucoma control. And they kept the warnings in any way, saying that their lawyers suggested that they should protect themselves by having the warning in there. There is one exception, and that is steroids as an ointment or drop used around the eye, or creams, or prednisolone or cortisone taken by mouth. They can raise the pressure in the eye because they reduce the turnover of glycosaminoglycans in the trabecular meshwork, which still are being produced, and they build up and can block the drain, just as happens in primary open-angle glaucoma. So as I say, this is a non-existent group of people who need this warning. Who can play on the team? Compliant patients, ocular hypertensives. When do we need to send in a substitute into this football game? Well, initial laser treatment for some with physical or mental disabilities, or no one to assist, or by choice. It really is an equal choice, trying medicine first. And the patient who shows up with one eye already blind from glaucoma, and they haven't managed to deal with the medical system, have gradually and slowly gone blind in one eye, who are non-compliant with meds or visits, you need to talk to them about surgery as the initial management for the condition, because unfortunately, people do not change that much. If they're not able to deal with the medical system, it usually stays that way. And if they're non-compliant, it usually stays that way. Some people may be able to change, like the Apostle Paul on the road to Damascus, but the majority of people who have problems complying, it continues. And if after instruction they are still non-compliant, it's best to operate. And if they show up with a lot of damage, it's best to operate. And we'll be going through glaucoma surgery as well. But if you take time at the diagnosis to explain the patient what is the disease in terms they can understand, that there is a real risk of loss of vision if it's not treated and followed up, that this reduction in risk with vision loss can be reduced tremendously with successful treatment. Talking about the treatment options, given written materials and to have their instructions and a website address, some more backup information from a website address. Develop a treatment plan that reaches an appropriate target pressure that makes adherence possible using color-coded written instructions, and training the patient and caregivers how to give the drops and check their ability and ask about compliance at the next visit and watch them take the drop. Ask about impediments, side effects, cost, memory. Monitor the patient's condition with optic nerve imaging and visual fields, and discuss the results with them. This is very reassuring to show people, look, you know, we've been doing this test now for the 2 or 3 years, and you're not getting any worse. And if the vision is seemingly getting worse, maybe it's a cataract or something else, or need to change their glasses, or they're getting presbyopia, But you can reassure people that, look, we're not losing tissue, we're not losing function, and therefore you're doing well. Or if they are getting worse, you can show them why you want to go on to the next treatment, be that laser or surgery, and why it's necessary. And they can see for themselves. They don't need to go out and get a second or third opinion about what to do. It's not just an opinion. It is based on very clear results of monitoring. And people, if they understand why you want to do something, and you have good evidence for it, they are usually quite willing to go along with it, of course. And that's a plan for a winning team. Thank you very much. Are there questions? Okay. It's a long one and a lot of information there. Are there questions? You want to take about a 5 or 10 minute break?
Sure.
So for the interval, we'll just show some Monet paintings. This is from Monet's garden in Giverny. You can actually go there in July or August and see these beautiful flowers. Monet, by the way, had cataracts that made his vision blurry. And his impressionism really was based on his poor vision. Before that, his paintings were more precise. And after he had his cataracts taken out, he, well, when they really got bad, he started painting everything orange and yellow because he had kind of reddish brown cataracts. And then afterwards they were taken out and he saw all these beautiful blues and purples and greens. And he said he didn't like them, but he painted them and we love them. How strange. But this is the sort of thing he painted when he had the cataracts. They're very, very, very blurry and a lot of red and yellow. And here are the haystacks. And this is his garden in Giverny again, which you can go and visit about 30, 40 miles outside of Paris. The French don't seem to know much about it. It's the Americans that are crazy about Monet. Haystacks, here's sunset, the poplar trees, and the beautiful lily ponds that are there. If you go in August, late August, they're beautiful. And these fantastic lily ponds. The best museum to look at them in is the Montmartre in the 16th arrondissement. It's a relatively small museum on the north side of Paris. And most people have gone to the d'Orsay and other places to look at his paintings, and there are wonderful paintings there, but the very best ones are in the Montmartre museum. And then there's a good collection in Chicago as well. And then he painted quite a few of the cathedral at Rouen. This is earlier on in his career. You see, he painted things more precisely before his cataracts got worse. And this is some of his really early work where you see he was painting very conventionally when he could see clearly. And then later getting blurrier. I think you painted this in London. Oh, wait a minute. This is again in the gardens. There's that bridge you can walk over, the footbridge. And then the original paintings that Impressionism came from were these paintings of sunrise, Impressionisme. One of these paintings is missing from the garden, from the museum. It was stolen, and I happen to have a painting very much like this in my house. But I'm not going to say that it's the original. Okay, it's time. Everybody's back, hopefully, and let's go on to the relationship between intraocular pressure and damage, and what we've learned about that over the last 50 years. And now have a very precise picture, I think, and something that at the end, I think could be a real paradigm changer in our management of glaucoma. And then tomorrow, we'll be going into surgery, and particularly how to do surgery that's effective and how to avoid complications, and how to fix complications should you get them. That's actually what I'm mostly known for, unfortunately, is how to fix complications. And then finally the Zen and the microshunt, which probably will replace a lot of trabeculectomy once the price for these things comes down when they're made generically someday. But they certainly reduce complications considerably. Well, let's go on with the narrated Norton lecture. I gave this at Bascom. I was visiting professor in my own institution, and it tells the evolution of our understanding about the risk of damage related to pressure. And slideshow from the beginning.
Good morning. These are my disclosures. The latter two may be relevant. I also want to disclose that I met Dr. Norton in 1948 at a Christmas party at the U.S. Naval Hospital in San Diego, where Dr. Norton and my father were in the ophthalmology department. My father, who is an ophthalmologist in the Navy, also in Japan, operated on children blind from cataracts and helped train a Japanese doctor. And this became a model for my later wanting to train doctors from other countries. My contract when I came here in 1980 said, number one, the patient comes first. Second, empower the doctors in the community. And three, I'm hiring you in glaucoma, but if you later wish to do something else, follow your dreams and I'll support you. The talk that I want to give in Dr. Norton's honor today is the coming paradigm shift in glaucoma management. Where do paradigm shifts come from? This is my 1959 electric typewriter on which I typed work for high school and college. Well, that's of course been replaced by computers. Dial-up telephones connected by a wire have in large measure been replaced by cell phones. So paradigm shifts come about when there's either a new understanding of a problem or disruptive technology. Are dealing with infection, are dealing with such things as blood pressure and diabetes, retinal edema in diabetes and wet ARMD, or understanding the genetic basis of the disease, when followed by disruptive technology that allows us to deal with them, changes everything. And this is about to happen in glaucoma. Now, the best treatment for eye diseases is based on disease impact and the risk benefit and the cost of available treatments. In cataract, phaco, and foldable intraocular lenses certainly moved surgery earlier. In wet macular degeneration and diabetic retinopathy, the anti-VEGF agents, laser and steroid, have given us a wonderful ability to deal with these problems. In glaucoma, however, we have been stuck for a while with meds, laser, and surgery because of uncertainty about whether a patient was likely to progress or not, because of the risks of the very effective treatments of trabeculectomy and tubes, but that is what is about to change. What is the risk that your patient is going to progress at their current IOP? Here's a patient of mine who came in with elevated pressure from chronic angle closure and initially had some damage on the visual field at the top. When put on treatment, pressure came down, the field appeared to improve, and after a little while later was borderline. On OCT, there was clearly some damage. Now, the American Academy of Ophthalmology recommends at least a 20% reduction. But is that optimal? Somebody comes in with a pressure of 26. Are they really going to be that much better off if they're at 20? Or wouldn't they do even better if they were at 17, 14, or even 11? But which patient might need that? So the paradigm shift that's coming is due to new evidence about what optimal treatment is in advanced damage and in early damage. New MIGS surgical procedures that have lesser risks operating on the angle and even the suprachoroidal space, although those have been withdrawn. And mostly safer substitutes for trabeculectomy, the Zen and the pressor flow microshunt, both of which, as I mentioned, I was involved with. And the latter definitely has less hypotony and less lens change than trabeculectomy, as shown in the pivotal trial in which I was the medical monitor. But also coming along, as I'll discuss at the end, is a way of detecting apoptosing retinal cells that could let us know which patient is likely to progress and how we could therefore identify those in whom taking more risks to get the pressure down would be worthwhile. Well, let's go back and let me walk you through my experience with this topic. Sunday afternoons in St. Louis. I was at Washington University, St. Louis as a glaucoma fellow with Dr. Bernard Becker and Dr. Michael Cass. What's a fellow to do? How in 1 year does one get a long-term perspective on a chronic disease that is usually slowly progressive? Well, you have to learn from the past. So on Sunday afternoons after church, I would go in and review the charts of long follow-up cases. And what I saw with 10-year follow-up is that low normal intraocular pressure, advanced damage cases were stable for a decade in nearly all cases. But in the high teens, most similar patients progressed substantially. And that went against the prevailing view that high teens was the goal. After all, those are normal pressures. One could only slow the damage of glaucoma, it was thought. But I wondered, couldn't you do better? And what I saw in those charts suggested we could, if only we had effective and safe ways of getting down to those pressures. Well, I found out that Paul Chandler had beaten me to it by about 17 years. And that's why I call this aspect Back to the Future. He had already noticed that patients who had advanced damage needed lower than the average pressure of the population in order to be stable in most cases. We have now had many randomized clinical trials in glaucoma, spending over $100 million of government money to do it, and have found out that for the most part, this is correct. Although now we understand more than he did
about the precise relationship between pressure and the risk of getting worse. And also, we now have solid evidence that part of the damage can be reversible. So what he said was that eyes with advanced glaucoma require a pressure below the average normal. Eyes with limited cupping, confined to one pole of the disc, appear to withstand tension better. Mild initial glaucoma might do okay in the mid to upper teens. Eyes with a normal disc, that is ocular hypertension, can withstand pressure well over many years. And the appearance of the disc serves as an important guide to the management of glaucoma. To understand the relationship between intraocular pressure and the risk that someone will get worse, we need to ask two very different questions. The first is, how much of glaucoma damage is associated with an excess pressure distribution? If you were to do a receiver operating characteristic curve, which I'm not showing here, you would find that only about 1/3 of glaucoma damage in the study on the left-hand side in England was associated with a higher pressure distribution of pressures than is seen in the general population. And as you can see, there's quite an overlap between the glaucoma cases shown here in gray and black bars and the logarithm distribution of pressures in the population. At least 1/3 of the patients with glaucoma are having damage taking place in the normal pressure distribution. There are racial differences, with 3 to 5 times the risk in the middle panel there of glaucoma damage at various pressures in the African American population of Baltimore compared to the white population. Now, the situation in Japan is even worse. Only 1/10 of glaucoma in Japan can be associated with a higher pressure distribution, as the average pressure of a glaucoma patient is 15.6, and the average pressure in the population is 15. But there's another question, and that is, how much of glaucoma damage is pressure dependent and avoidable? The surprise answer is nearly all. How can that be? The answer appears to be that intraocular pressures near episcleral venous pressure might be compensating for whatever else is wrong, either by improving blood flow to the optic nerve or reducing stress on the optic nerve where the ganglion cell fibers pass out through the lamina curvosa. This is not at all like blood sugar and diabetes or hypertension, where upper normal would be a reasonable goal. And the advent of anti-metabolite filtering surgery allowed us to prove the benefit of low normal pressures. And for that, I was quite fortunate to be at Bascom when Mark Blumenkrantz suggested to Richard Parrish that 5-fluorouracil be tried in filtering surgery. Of course, now we use mitomycin, but 5-FU paved the way, at least for our experience. In 1982, on May 11th, I performed the first operation with 5-fluorouracil at Bascom in preliminary studies based on Rich Parrish's studies with monkeys, which was preliminary to Rich Parrish as an assistant professor being the head of a multi-center clinical trial that showed that the failure of glaucoma surgery could be cut in half with the use of these agents. By 1988, I had developed a valve-like filtering procedure such that the pressure in the eye was about 5 millimeters of mercury just from the wound construction, and then carefully adjusted to about 10 millimeters of mercury intraoperatively, which could be estimated by watching the flow to equilibrium and then estimating the pressure by pushing on the cornea. This allowed me, with first 5-FU and later mitomycin, in 212 operations, to take patients who'd been referred to me, mostly by the community ophthalmologists in Miami, Maria Guerra-Galendez, Leonor Murias-Boudet, and many others, to operate on their patients and take the pressure from 26 millimeters of mercury on full medical therapy to what I tried to be 10 millimeters of mercury in the range of 8 to 12. And indeed, the pressures ended up being about 11 during a decade of follow-up. Now, during this period of time, about a third of the patients failed, and we did another operation. But this is the relationship between the intraocular pressure and what happens to the visual field, which was reported, is worked up by Kyoka Ishida and Erica Escalona as fellows and Joyce Schiffman as a biostatistician. And this technique was published as Sunyer et al. In ophthalmology in 1997. Well, what was the result on the field? The result was a slight improvement in the mean deviation, which was sustained during follow-up. Everyone stays in this study, even if a second operation has to be done. No one drops out because of failure. Now, if you look at the change in mean deviation in this group of patients, there was no net loss from their baseline during follow-up, nor was there a change in the pattern standard deviation. There were some patients who appeared to progress on 2 consecutive fields by 3 decibels of mean deviation, but there were about an equal number of people who appeared to have improved. I thought at the time that Dr. Ishida showed this to me, that this meant that we were looking at noise. If you do a test over and over and over again, some people are going to look a little better or look a little worse by chance. But it turns out that that's not the explanation for a lot of these cases. A lot of them, these changes were real. And the reason we know that is that if it were noise, it shouldn't correlate with pressure, and it did. The mean pressures weren't different, but the maximum pressures were definitely statistically quite a bit higher in those patients who had progressed versus those who had not. Now, before you get excited about whether the maximum pressure or the mean is the most important, it all depends on the study design. In surgical studies, the peak is going to look most important because people are low and then go up and have a peak. In observation or medical studies, such as the early manifest glaucoma trial, peak didn't look important, the mean did, because people were at a fairly steady pressure, which was either adequate for them or too high. And in those studies, the mean looks more important. What's important is to have consistently low pressures to get the maximum benefit. Well, in our study, none of 15 patients whose pressure was always 13 or less got worse during long follow-up, even though they had started with about 14 decibel mean deviation. Whereas anybody who ever had a pressure of 14 to 21, 21% of them looked worse. And if they ever got over 21, of course, we intervened as soon as we knew it, but even by that time, 38% had gotten worse. Now, I wondered, how could we have people getting worse and the mean not changing? And the answer was that those people with those pressures of 13 or less had actually improved by about 2 decibels, as we detected at the first annual visit afterwards, and this was maintained. Whereas those patients who were in that intermediate group had improved by an average of about 1 decibel, and the other patients, initially with good pressures, were stabilized. They had not improved, but they were stabilized for several years until their operations began to fail or failed, at which point they actually became net negative. So that's the answer. The reason that the mean didn't change while some people were getting worse is that some people really did get better. About a 14% improvement, 2 decibels out of the 14.6 decibels of mean deviation they started with. Now, for the first few years that I presented results at ARVO showing 5 years of no net visual field loss, I would hear people murmuring behind me at my poster, saying things about how this couldn't be real, that somehow I had to be faking this, or that because I'm an evangelical Christian, I somehow thought that I had magical powers. And it was very frustrating that people were ignoring good science because of their feeling that, no, you can't stop glaucoma, you can only slow it down. And the posters all around me were showing that people were getting worse, but it was happening at pressures in the mid to upper teens. When, as a member of the Advanced Glaucoma Intervention Studies Monitoring Committee, I asked and fought for 3 years to get the people running the study to look at what's the best we can do if the pressure is always low. And the analysis finally came out that, well, if you're always under 18 and you're averaging 12, very much like my patients, there was no net visual field loss. Whereas if you were in the mid to upper teens, in these patients who in that study had about an average of minus 10 decibels mean deviation, people did get worse. And this explained the difference between what I was reporting and what other people were reporting who were not doing anti-metabolite filtering surgery. Well, I was a co-recipient of the World Glaucoma Prize for asking a question. I had not done any of the work. I wasn't even an author of the paper, but I definitely had fought for getting the answer to the question, what's the best we can do? What is the dose-response relationship between pressure and the risk that you will get worse? Now, not everybody needs a pressure of 12 in order to be stable and well served. And it was never my point to say that everyone should, with glaucoma, had to be reduced to that level. This was often misunderstood. I was just talking about the science. You had to weigh a lot of things to decide what to do about this information, including the risk of trying to get somebody down there. But this is the science that we need to understand. Now, as I say, not everybody needs that kind of pressure, but your odds improve. 13% of patients look better, 13% worse if you were down in this consistently low group. If you were around 15, the average of the population, 30% of the people in the study got worse. And that was 4 Aegis units, which is about 5 decibels of mean deviation over the course of 8 years. And if you were really up around 20, even though they would intervene if you got above 18, at least about 70% of those people had gotten significantly worse on consecutive fields. Now, how can we identify these people who need those lower pressures? We'll get to that. Now, having a target pressure, this term that I introduced in 1988 in helping to write the preferred practice pattern for primary open-angle glaucoma, when Al Sommer was the head of the committee. Having a target pressure really is effective. And if you don't have a target pressure, as in the early manifest glaucoma trial, where patients with just diagnosed glaucoma and about 5 decibels of mean deviation were randomized to either observation, which is the black curve on the left panel. 62% of them got worse on consecutive fields. And if you were treated, but without any target, adding Betoptic twice a day and laser trabeculoplasty in these Swedish patients who were recently diagnosed, 45% of those had gotten significantly worse. Now, that's statistically significant, but clinically kind of disappointing. On the other hand, patients at diagnosis who were randomized in the collaborative initial glaucoma treatment trial, shown on the right, had no net progression with a target pressure that was at least 30% reduced from their baseline. And in the case of surgery, their average pressure had been reduced to 14, but they didn't use any metabolites all the time. And with medical therapy had been reduced from 27 down to 17.5. And neither group showed progression on average in the first 7 years. Now, I was a member of that monitoring committee as well, and I actually was the only member of the monitoring committee of both AGES and SIGES, which gave me an opportunity to think about what was going on. And as a member of that committee, after we got on a few years, I said, how can we have no net progression, and yet 20% of the people who were out to 7 years by that point had gotten worse by 3 decibels? And the answer was, there were some people who looked like they were getting better, an equal and opposite number. Now, I thought that was noise. Here are the accumulations. This was published in a paper that I asked, asked the question, can you analyze this and publish it? Showed that the number getting better and worse was about the same as shown in this plot. And as I say, I thought it was noise, but I was wrong because it correlated with pressure. And if it were due to noise, it should not have correlated with pressure, and it did. It also turned out it correlated with other features. It correlated with gender. Women were 60% more likely to have a recovery of visual field, and people who had had cardiovascular disease, heart attack, or stroke at some time in the past were less likely to be improved. So there was a dose response for the improvement. If your peak was 13, then your percent of visits, there are 10 visits in the first 5 years, 18% of them looked better by 3 decibels of mean deviation at that pressure, and then progressively less as you got to lower values. Now, how can you sort out signal from noise? And the idea occurred to me that the way to do that would be to subtract the percentage of people who look better or worse. And in the study, if you look here, people whose pressure was 13 or less, always, 18.7% of the visits looked better by 3 decibels, 6% worse. And in that study, noise was about 5%. So that indeed, the difference has to be real, and it showed a net improvement in about 1 in 8 subjects. Whereas if you're pressure 14 to 17, the noise was still probably about the same. You had a lesser percentage of people getting better. And as you went to higher and higher pressures, you were breaking even or you were net worse. Now, the only reason we did this analysis is because Kyoko Ishida, as a fellow, had pointed out to me the improvement that could happen at low normal pressures. And really the credit has to go to her for having the insight, which I simply asked for the same thing to be done with SIGES. So we've seen there's an advantage in stabilizing fields and even improving fields if you get to low pressures. Now, if there were only a way to get those pressures safely, and if there were a way to identify which patients are the ones who need them, we could start having individualized care in glaucoma, which would be a huge advance. So how do I want to interpret all of this? If you are somebody whose peak pressure was 13 or less, the improvement was real at least 2/3 of the time. So we know it can happen. But about 1/3 of the time, you really couldn't tell whether it had been real or noise. And overall, only about 20% of the time, apparent improvement is necessarily real, and up to 80% of the time, it may have been due to variability repeated testing. And it also means, and we've seen this in other studies like oaths, that people can get worse or get better from test to test, and you just can't depend on one test unless it's really remarkably different, or you have some confirmation, either repeating the test or showing focal loss or structural change in some way to measure the presence of dying or stressed cells. Now, you've heard of the pattern electroretinogram as potentially being something to do this, but there is now another way to do it as well, which I'll talk about. So the way I'd like to see target pressure concept applied is use the data from clinical trials to inform your goals and choices. Modify it, of course, by the experience with the patient. If you followed somebody for 5 or 10 years, you have a track record that they were stable or getting worse, that trumps the percentage risk of them getting worse from clinical trials. And then you have to weigh the risk and benefit of the current pressure versus an intervention at various pressures. Then you have to consider the life expectancy, the visual needs, and the preferences of the patient. It's their eye. But you can get visual field stability in early glaucoma with pressures of 13 or less, and some improvement in some. In patients with advanced loss, we saw the same thing, about a 14% recovery of visual field at an ideal target pressure. But if we pursued that in everyone, we would be treating everyone aggressively to benefit a minority of people, and there would be offsetting risks of surgery. That might be acceptable if the treatment were extremely safe and long-lasting and not too expensive. And certainly the Zen, and particularly the in-focus microshunt, for which we have randomized data against a trabeculectomy, do show a cutting of hypotony maculopathy to 1/3 of what it would be otherwise, and a cutting of cataract to half of what it would be otherwise. So that makes it safer. And I will be discussing the Zen and the microshunt substitutes for trabeculectomy in a later lecture today, and also some key observations from those clinical trials in which I was involved to guide how to do them. Particularly, it's very important that the tip of the tube not be in Tenon's capsule, but be under it, because the constant rubbing of the tip of the tube on the outside of the eye against Tenon stimulates the formation of a fibrous cap. So the tube either needs to be above or below an intact Tenon's capsule. It's safer below. And it needs to be off to the side, not up at 12 o'clock where Tenon's is thicker. And you need to use a significant dose of mitomycin, and you need to test that the pressure equilibrium flow is what you want it to be, that you have not in any way pinched or obstructed the tube. But if you do all that testing intraoperatively, they're very effective. So we would really like to stabilize fields. We would like to improve them, but we want to particularly focus aggressive treatment on those who need it. It would be far better if we could selectively treat just the amount needed for that individual. And here we go. This, I think, will be the final very important insight for individualized glaucoma therapy. Let's imagine it's 2025 and the FDA and the European Union have approved something called DART, detecting apoptotic retinal cells. Professor Francesca Cordiero at University College London and Imperial College London has been working on this for 25 years. And what she has found, as others have, is that when ganglion cells are stressed by high pressure, they will go towards apoptosis. And in this process, receptors for annexin come to the surface of the cell. She developed a probe, which is annexin 5 with a fluorescent probe attached to it that you can inject into the vein of a patient, and 2 hours later, using an OCTA instrument that we already have, you can measure the number of cells that light up by binding of the annexin 5 with the fluorescent probe. And they have now a convoluted neural network, CNN, for counting those cells from the images coming out of an OCTA instrument that has the right wavelength to look at this. Now, her original work were just manually counted spots, which are harder to see necessarily. But with a convoluted neural network, they're able to sort out cells that are just being stressed and have not got as much binding. But here, this work published in Brain showed that in a glaucoma patient, in the top panels, you see several cells had lit up. And with normal aging, only one cell was seen to have lit up. And these are at various times out to 2 minutes. But now, with the convoluted neural network system, they're able to count far more cells. And here's a glaucoma patient. And this is automatically counted by the algorithm. And she was able to show in patients whose pressures were only in the upper teens. So sorting out people who then progressed over 2 years with OCT was quite statistically significant in those who were stable and those who were progressing. So she needs to have a phase 3 clinical trial. They're looking for $30 million to $50 million to do the study for the FDA. I don't have any financial interest in this, but I have an enormous intellectual interest in seeing that this be done. And I've been talking to Genentech and Allergan and Alcon and anybody who will listen to me, that this study needs to be funded and done so that we can find out if these preliminary results in turn will actually turn out to be as useful as they look. Because if they do, glaucoma therapy in the future will be different. It will be individualized by knowing the current rate of cell loss. Now, you probably would want to stage the patient certainly by function with a visual field and by structure with OCT to know how much damage has taken place. But you'll now also be able to know the rate of cell loss taking place now. So you'll get an idea what your initial target pressure goal should be. And then after you've done medical treatment and perhaps laser, you're going to find out, is the rate of cell loss now down close to that of aging, or is it still substantial? In which case you would probably want to intervene further to get the pressure lower, but you'll be doing it on a selective
basis. And then that would enable us to have individualized care for people. I'm going to get rid of that call. All right. Now, any questions based on this study about the hopefully coming paradigm shift? Comments, questions? Or about the clinical trial results?
Yes, Doctor, one question. If we could, I don't know how to put this. Is this something that we could see in the foreseeable future? Like could that be easily adopted, or is this something more of a, I don't know, for a private sector or something like that?
Well, what we need is for somebody to get this approved by the European Medicines Agency in Europe and then into Latin America, or by the FDA and then into Latin America. As I say, this seems pretty obviously a potentially very, very important breakthrough, and it's
yeah, I believe it could be as useful as, I don't know, an OCT or something like that. Another study that would give us more information on how to.
So but the problem is, so far the companies that I've talked to about this, and I'm not a representative Dr. Cordiero, but they need to come up with money. And for some reason, no company has wanted to be the lead on doing this. Maybe they think that if they get it approved and spend a lot of money doing it, and what you would do would be to test this on people at their diagnosis and show that they're losing a lot of cells, and then lower their pressure and show that they stop losing a lot of cells, and perhaps correlate that with OCT change later on, and show that what you need for the FDA is that whatever you say your product does, it does it. And if this shows cells that are dying and then lowering the pressure, it goes down, a lot, then and it turns out to be predictive of who loses visual field or OCT structure later, then that's something that we definitely are going to want to use that information and not wait for somebody to lose another 10 or 20% of their visual field or another 10 or 20% of their nerve fiber layer or macular ganglion cell layer. So, I mean, it's just such an obvious thing to have an exon screamometer, but I suppose it's a matter of either the patent wouldn't last long enough to make a lot of money for people, or they think, well, somebody else could make an exon and could make a system to do the monitoring. But all it involves is the injection into the arm of a patient of this Annexin 5, and that's already been through phase 1, it's safe. And 2 hours later, scanning the patient with, in both eyes, with the OCTA machine that has the right wavelength already to do this measurement, and the algorithm is there for the computer to look at the pictures and count the spots. So that given that everybody, that most people do have some access in their city to an OCTA machine, it's not going to take a lot of expensive new equipment. So it's pretty obvious to me that if I were taking care of glaucoma patients, or if I had glaucoma, I would want to know, are my cells dying under treatment? Are they dying at the rate of aging, which is okay, it's slow enough, or are they dying faster because I need a lower pressure? And so I'm really eager to see this somehow get approved. I think it would change everything, and it wouldn't be difficult to adapt, provided it doesn't cost too much for the injection and for the algorithm to use on your computer.
And that I guess that also could be helpful for example, I've seen a few cases with low tension glaucoma.
Sure. I mean, if cells dying. By the way, if you can focus the OCTA deeper than the nerve fiber layer, it can also be used in atrophic macular degeneration to see cells that are dying there, because it's apoptosing retinal cells. It's not specific for ganglion cells. It's for any cells that are dying by apoptosis. And those are two major diseases that would be better monitored in this way. Now, companies are investing in using it to test whether new drugs against atrophic macular degeneration, the loss can be slowed by some new medications that interfere with the complement system, where we know that there are some genes associated with macular degeneration. So it's, hopefully during your careers, sometime in the next 5 or 10 years, somebody will put the money out, they'll get this approved, and it'll become available, and we'll be able to individualize treatment of glaucoma patients based on cell death. It's either you've gotten it down to the rate of aging, which is very low, very slow, about 0.4% per year, or just like cells in the cornea, you have less, and then in your brain you have less as you get older. And I think it would just be what's needed to take what I've developed in the target pressure concept and all the data from AGIS and SIGITs and EMGT have given us really good statistics on the percent chance that your patient will get worse at under treatment at various pressures at the time that you've done your intervention, which gives you a guidance.
And we have new operations that we'll discuss tomorrow that are safer, and there are ways of doing even trabeculectomy that are a lot safer than most people are doing now, that I will discuss in detail tomorrow. We're gonna do, I have a lecture I give, or a course I put on at the American Academy every year. It's about 75 minutes long, and it's everything that I know about trabeculectomy and tube surgery, and how to avoid problems and how to get them working more effectively. And they give the kind of results I showed you, which was no net visual field loss for 10 years. You can do that. And but also ways of when you do have problems with blebs that are uncomfortable or leaking, or you have problems with hypotony, there are very effective ways of avoiding those problems, and even if they do occur, of fixing them, that I will talk to you about tomorrow, and that for some reason are not always understood by people, even glaucoma specialists. So let's see, we've got about 15 minutes. Are there more questions? I do have one more short thing I could show you.
I'm sorry, I think I'm taking up all the questions, but
Yeah, it's all right.
Another thing, because I'm actually quite interested in this low tension glaucoma, because the grandmother of a dear friend of mine has it. Her pressures are 8, 10 on the right eye. She already lost the left eye. And even with those low tensions, per se, we still have a little bit of damage in the nerve year after year. We do HRT test and OCT test constantly, and we see there's like, and the visual fields are also diminishing
Okay.
year after
Now,
year.
is this on medication that pressures are lower, or surgery?
Both. We actually did, we had her with 3 types of medication, and last year we switched to Rocklatan, I think it's called.
Yeah.
And we also did micropulse laser therapy.
Mm-hmm.
And she got to 8, and still there's a little bit of diminishing of the how can I say this?
Okay.
Yeah, the visual fields. Yeah.
Okay.
Also, the micropulse may have had a little effect on the macular area, a little edema. It sometimes happens, like a transitory edema. But
Okay,
still,
so let me just say some things about normal tension glaucoma. There
Okay.
was a normal tension glaucoma trial, and it showed that these were people who's never had a pressure that was above 20, and I think they averaged about 15 to start out with.
yeah, that's
and
correct.
they were randomized to observation. This was in a Caucasian population, to observation versus treatment. And the treatment did not include Timoptic, and they didn't have prostaglandins. So it was like pilocarpine and Diamox or surgery. And what they found was that if you have normal tension glaucoma, not everybody with normal tension glaucoma progresses during a period of time that they watch them. And to get into the trial, to be randomized, they had to see some progression. And so these patients who are higher risk, that is, they have been progressing and were randomized, you cut down by about 2/3 the percentage of people who are getting worse by taking them from 14 to about 11. So pressure does matter. There was a study in Japan where they randomized, not randomized, they took patients who they operated on with mitomycin and got them down from about 14 or 15, got them down to 9.5 with surgery, no medicine needed afterwards. So you're not dependent on medication compliance, or you have good outflow. And they found that 96% of them were stable for a decade. And if you didn't get the pressure down, that something like 90% of them got significantly worse in a decade. So in Japan, different population, where 92% of the glaucoma in Japan, of open angle glaucomas, are normal tension, and the same thing in Korea. so that there's something else quite different going on there, but it is still very, very pressure dependent. Now, there was a study done by Eric Greve in Holland where they and in England, there was a study where they took people who had normal tension glaucoma and they either had them on and had their pressures fairly low with medication, sort of like not 8 or 9, but maybe 11, 12, 13. And they randomized them to surgery versus staying on medicine. And the rate of getting worse was cut to 1/3 in those who had surgery. And the problem is this: you can be on medication with a pressure of 9 or 10, 11, 12, something like that, but your pressure actually could be quite variable during the day because you still have very poor outflow. Hemo Susana in São Paulo, he does a water drinking test. He has people drink water, and if their pressure peaks, it's at a higher than a certain amount when they drink a large quantity of fluid. It's like 750 milliliters or a liter. That those are people who progress twice as much as the people who don't have their pressure go up that much in people who are on medical treatment for glaucoma. Now, I don't do that test, but I do ask patients about their water drinking if they have very advanced glaucoma, and particularly if, like you're describing, somebody who's getting worse. And I had one patient come in and I said, do you happen to drink? His pressure was always good, but he was getting worse. And I said, do you drink much water? He said, oh yes, water is so good for your health. I drink 6 liters a day. And I said, okay, come into the office, bring a liter of water and drink it, and let's see what happens to your pressure 30, 45 minutes later, an hour later, which is how Hemo has described this. And the pressure would go to 28 and it would stay up there for an hour or two. And he was doing this 6 times a day. Well, I told him, look, we can, you can drink water, just spread it out. Don't drink more than a glass an hour, and then we won't have these pressure spikes, or we can operate. And he says, I'm not giving up the water. So I said, okay, let's operate. And he said, okay, so we operated. And I don't have enough follow-up to tell you that stopped him getting worse, but that's why I asked whether it was down to 9 with surgery or it was down with medication. And also I would ask your relative, do they drink a lot of water? And if this is somebody who thinks that's really good for your health and they're drinking a lot of water, well, check it, when they drink a lot of water all at one time, check the pressure 45 minutes, an hour later. And if it's going up to 20, 23, 24 and staying there for an hour or two, then I've got a suggestion for her.
Yeah, spread the water.
Either spread out the water, and in people with advanced damage, I tell them that anyway, unless you're dehydrated from being outdoors, spread the water out. Glass an hour is fine, your kidney will keep up with it, but don't drink large quantities all at once. I have a patient who says, well, I drink a big gulp from 7-Eleven. That's 64 ounces of water.
Yeah, absolutely.
I can't even imagine a stomach that could hold all of that, but nevertheless, I'm glad you brought this up about normal tension, because I guess I didn't say enough about it, and I think I may have briefly gone over the data from that, or I intend to tomorrow. But this is good that we're talking about normal tension glaucoma, and my answer is being on medication and having the pressure down doesn't assure that it's down all day long, and particularly having to do with fluid intake. And patients sitting in your waiting room for an hour or two, not having any water to drink, aren't going to be the same as they may be,
all day long.
Yeah. So as far as your relative is concerned, that is the one thing I can think of, is that I would find out about water intake, and if they do have a lot of water intake, well, test and see empirically, what does it do to the pressure? And if all else fails, I would recommend surgery. And I don't mean micropulse, that doesn't change your outflow significantly. I mean, there may be some claims about it, but generally it doesn't. I think that filtering surgery that gets a steady pressure all day long, and it's not going to peak at various times. It doesn't depend on compliance. Doesn't depend on water intake, because then when you've had a really good filter working with a pressure of 10 or 9 or 8, the pressure doesn't go up when you drink water.
Yeah,
so
absolutely.
Those would be the things I would say about that. I think we've got about 4 minutes left. I'm going to very briefly mention something, which was the pattern electroretinogram. When I gave the talk on, when I was the discussant of the paper, and this was done by Porciati, who was in Italy and then came to Bascom where he works, that this is like Horton Hears a Who. Now, I don't know how many of you know this kid's book, but apparently this elephant had extremely sensitive hearing, and he could hear the who's, little tiny creatures that were about to be destroyed. They lived on a flower and somebody was about to pick it. And he could hear them saying, we are here, please, you know, don't kill us, you know. And so this brought up the question of, can we detect ganglion cells problems? And it turns out that if you give the ganglion cell a stress test, you know, people with heart disease, they get you on a treadmill and you walk as fast as you can. And they see what happens to your heart during that time. And sometimes they'll even measure the ejection fraction, or they will see what happens to your electrocardiogram. And it turns out that that stress test finds out how much reserve you have. Well, there's a similar thing for the ganglion cells. Ganglion cells only fire when they're presented with something that's changing. If you can hold your eye absolutely still, your sight will go out. It's an amazing thing. But normally we have these microsaccades that keep that from happening. And what happens is that you can present alternating black and white horizontal stripes to the one eye at a time. And then you can measure the electroretinogram by putting electrodes, you know, here and in the back of the head, and measure the electricity that is produced by this. The waveform, is it delayed? Is it lower than normal? And when this is done with the Palmberg machine, in normal people, you get a normal response. If somebody has let me show you this one, has early distressed ganglion cells, the pressure has gotten a lot higher fairly suddenly, you have a decreased Palmberg. But if you then lower the pressure, and they've done this in some ocular hypertensives who had abnormally low Palmberg responses and restored the function. So under normal circumstances, these people had a normal visual field, normal OCT, but the pressure is affecting the function of the cells, and lowering the pressure brought it back. And I think the reason that we sometimes see visual fields worse first is that cells haven't died, but they are being stressed. And then sometimes you have cells that are dying, but you don't detect that on the field because of overlapping fields of the ganglion cells, or the fact that you have to lose, for example, half of your ganglion cells to get a 3 decibel change in the visual field. You don't have to lose half your ganglion cells to see a change in the OCT. I mean, one of these things is logarithmic, and so it gives you the impression that you're going to see one before the other. If we had a much more sensitive way of counting the ganglion cells, I'm sure that function dies before structure. I mean, you can't have a dead cell have function. Come on, I mean, that doesn't make any sense. But because of the one being a logarithmic measure and the other linear, you see it first, and that there's so much overlap between people. So once you have advanced damage, of course, you're not going to restore it because it isn't there. Now, I've shown visual field probably for the first time in a really effective way. In that Sigit's paper, we showed visual field recovery. And those are probably the very people who you want to lower the pressure a lot, because it means that they're losing function. There are cells that have lost function that can get it back. And they are probably the ones who are rapidly losing visual field. So we would like to find them with this new test. I think that the other test is probably going to be even better than the Palmberg because it actually measures ganglion cells that are in the process of not just dysfunctioning, but dying or being very stressed. And if you saw a lot of that, those are people not only that you want to stop them from getting worse, but they're also probably the ones where you can get something back because it's still in an acute phase of stress for those cells. So at any rate, here's some of their data about recovery, and the visual field recovery is better early than it is late with the PERG. So it is a way of monitoring ganglion cell health, and they're still doing studies to define exactly how that might be used in clinical practice. I'm not sure that we, it's a good experimental thing that they're working with, but I don't know that we know, you should run out and buy the machine at this point. Well, I think we have come to the end of the time. Now, tomorrow, we're going to talk about surgery, but I want to show you one thing. Well, I'll tell you about one thing that is kind of exciting. If you get an angle closure glaucoma, I want you to think about this. You have an angle closure glaucoma patient and their cornea is too cloudy to do a laser iridotomy. What would you do to get the pressure down? You start a lot of medication, you give them oral things like mannitol, or is there something that's quicker, safe, and fast? And I'll tell you what that is. So anyway, we'll see you tomorrow at, I guess you're having lectures on congenital glaucoma from Dr. Kumba and secondary glaucomas from him. And then I'll talk not about the things that are down there because they were kind of in reverse order to the logical development. I mean, surgery really should come after explaining the relationship, what's going on in glaucoma and how do you detect it and what our goals are. And now that in patients in whom the goal is much lower than where you're sitting, then we need surgery. So we're going to be talking about surgery, how to avoid defects. And this will come from my course at the Academy, which is like 75 minutes. And then a few other topics about the new devices, the Zen and the microshunt that I've been working on for 9 years. I don't have any stock in them. I was offered stock options, but I thought if I'm giving talks for them, if I'm a medical monitor, I shouldn't have it. I've blown several $100,000 by doing that. I did get paid for my time working for the companies, but just per hour. So I don't have a financial interest in them anymore. And but I do want to describe things that we learned about how they're very important things. They're not just a substitute for trabeculectomy flap. There are things that are very different. And as Ike Ahmed says, you got to forget everything you learned about managing conjunctiva and tenons for trabeculectomy when you're going to use these two devices. And I have found exactly the same thing as the medical monitor on this study. And anyway, tomorrow we'll be talking about trabeculectomy. We'll be talking about AMIDs and barbells, how to get them to work more effectively. And if you should have, how to avoid complications. And then if you should get them, how to fix them. And taking your questions. Well, thank you all. Have a good day, and we'll see you tomorrow.